Good afternoon, everyone. Today is Wednesday, January 28th, 2026, and it is 4:04 p.m. And as a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, do we have any committee members online, or do we anticipate any committee members to be online this evening? Okay, can you just let me know when he joins? Thank you. So, as a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So, for public communication, I would like to announce that we have a very hefty, long agenda, including the Board of Managers meeting this evening. And we have quite a few community members signed up to speak today at around 5:30 p.m. I am happy to take any public communication if it involves this committee agenda. If any community members, anyone has anything, if not, we can move all public communication to 5:30 p.m. So, with that, members, I just want us to also be reminded that, first of all, this is our first Budget and Finance Committee meeting of 2026. We are, I am very honored to chair this committee this year as well. Thank you all for your trust in me, and this is one of the most difficult committees, as you all know, and there's a lot of responsibilities that we as members of this board hold to be really good stewards to our taxpayer money and to ensure we are delivering the care that our patients need and to ensure our sustainability of services. So our commitment will always be to fulfill our mission and to provide care for those who need it most. And on that note, I would also want to take a point of privilege for 1 minute. Members, staff, community, these are really trying times. There's a lot going on in this world. There's a lot of hate, divisiveness, discrimination towards many individuals in this world. So I encourage us and urge us all to lead and to be guided by kindness and goodness, and that should be our moral compass, and to really to do the best we can to be the best version of us, and to treat everyone with dignity and respect, regardless of who they are, where they come from, the color of their skin, their accent, whoever they are. So that is really a message to us all, and that we hope to keep and maintain. So spread love and kindness to all, and hopefully this will be a better place for us and for our children and the next generation to come. So with that, I will proceed with our committee agenda. Agenda number 1, approve the minutes of the October 22nd, 2025 Budget and Finance Committee meeting. I move that the committee approve the minutes of the October 22nd, 2025 Budget and Finance Committee meeting. Do I have a second?
Second.
Manager Meg seconds. Any discussion? I see none. All in favor? Dr. Martin? All in favor?
Yes.
Okay, so the motion passes unanimously. Thank you. So we're moving on to agenda number 2, receive an update on Central Health Series 2025 debt issuance. Jeff Knodel and Blake Roberts of PFM will be presenting.
Thank you.
Please proceed.
Thank you. I'm going to introduce this real quick and then turn it over to Blake. This is related to debt issuance that the Central Health Board of Managers approved. The debt issuance went to market in November. The transaction closed in December. This was for debt related to the purchase of Northview, Promontory Point, Hancock Phase 2, and Colony Park. So I've asked Blake to come over and just give us a few highlights of the actual debt transaction.
Thank you, Jeff. Good evening, Board of Managers. My name is Blake Roberts. I'm a Managing Director with PFM Financial Advisors. We're the district's municipal bond advisor. I'll be brief in my remarks because we had a really good sale and you have a big agenda tonight. So that did not go for what there we go. So we are here to report on the bond sale that happened in November and closed in December. The district or Central Health issued $248.85 million of certificates of obligation via what's called a negotiated bond sale to a syndicate of investment banks led by JP Morgan Securities. The proceeds were used to fund the projects that Jeff just mentioned and approved by the board. The bonds were structured with a 30-year repayment schedule and a 10-year call feature. A 10-year call feature simply means that unlike a mortgage, which you can prepay at any time, the standard for municipal bonds is that there's a 10-year protected period where those bonds can't be redeemed or refinanced. At year 10, the district exercises the right to either refinance those bonds at lower rates or pay them off, or a combination of both. But there is flexibility embedded in that bond structure. The bond sold with a true interest cost, or effectively interest rate, of 4.54%. It's a really good result in the marketplace for your bond rating. And so we were happy with that result for a 30-year period. There was strong demand for your bonds. We had unique investor orders from more than 50 investors, totaling 1.9 times the amount of bonds offered. So almost twice the amount of bond orders as we had bonds available for sale. If you think about your Economics 101 courses, when demand for something exceeds supply, we can raise the price. In this case, what that means is you raise the bond price and lower the interest rate. So actually during the course of the order period, we were able to tighten the interest rate given the demand that we saw to even further compress the rate that is paid by taxpayers on the bonds. You can see the parties involved: municipal advisor, bond counsel, underwriting syndicate consisted of JP Morgan, Siebert Williams Shank, Piper Sandler, and Ramirez and Company. And underwriters counsel was McCall Parkhurst. On the next slide, this is small print, so I apologize, but we did want to give you a sense of the orders that were received for this sale. And this is really key and really great for Central Health because you aren't a frequent bond issuer. You aren't in the market every year with bonds. So you have a very strong credit rating, but the fact that you were able to combine the credit ratings with a really strong result here from a demand standpoint was tremendous. It speaks to management and how well for the financially run the district is. So you can see some big investor names here: Vanguard Group, Citigroup, PEMCO, Northern Trust, JP Morgan, Eagle Asset, Nuveen. These may be names you're familiar with if you have investments from a 401k with your own money. Lots of really premier investor names, which again speaks to the demand for Central Health's bonds. So very happy with overall what the district saw in the marketplace and the pricing day. Go to the next slide. So credit ratings were really, really important, and I apologize there. AA2, AA+, there is no scale context here, but what I will say is that AA+ is what the U.S. Treasury debt rating currently is. AA2 from Moody's is one notch below that. Again, that's really tremendous because it speaks to kind of the credit worthiness of your bonds and helps to lower interest rates that are paid and lower interest costs. So some of the credit strengths: good tax base, great economy, strong liquidity. Some of the credit considerations, just the nature of your business and exposure to federal subsidy risk and all that goes into that. So nothing unique to Central Health, but they do a holistic grading of you and came out with a AA2, AA+. So really, really good credit ratings that help with the bond sale. And then last slide, this is a depiction of interest rates. We don't borrow at a single rate. We borrow it based on what's called the yield curve. So a year one borrowing is lower than a year 30 borrowing. And so the brown bar is the tax exempt yield curve, and then you price to a spread to that yield curve. And so kind of wanted to show kind of how the interest rate benchmarks work when we price your bonds. I think that is the last slide I had. Again, wanted to be brief, really good result in the marketplace, especially considering kind of the infrequent nature of your bond sales. We were very pleased with the result. Happy to answer questions.
Thank you, Mr. Roberts. Really appreciate it. Just for the two board members, Manager Jefferson and Dr. Brinson, we're on agenda item number 2. Just want to make sure that you're aware. Is there any questions, managers, related to it?
A real quick
Yes.
question. When you said 10 years, so refunding can't happen for 10 years on these bonds? Is that, I just want to make sure I heard that right.
That's right.
Okay.
That's right.
Yeah.
You can pay for a shorter call date, but in this case, we weren't sure that that was needed, and so that 10 years is the
Yeah,
refunding
thank
date.
you.
Okay, thank you. I don't see any further questions. With that, thank you so much. Appreciate your coming to us with that update with some really great news to Central Health and our taxpayers. Thank you.
Thank you.
Thank you, Jeff. Appreciate it. Now moving on to agenda number 3, receive the December 2025 financial statements for Central Health. Nikki Riley will be presenting. Ms. Riley? So, I understand this is going to be probably a little bit lengthy compared to our usual, given that it's the first for this year. So the floor is yours. Thank you.
Thank you. Nikki Riley, Deputy CFO. I am going to try to hurry because I know that we don't have much time. There were some larger events that happened in the first quarter. I'm presenting December financial statements, so we've gone through October, November, December. I'll go over those and see if you have any questions. Other than that, everything's pretty unremarkable, business as usual, so I'll go over those. On the highlights page, on page 3, as you just heard, we issued $248.9 million of certificates of obligation for those projects. You're going to see that show up on our long-term debt schedule, and then you will also see for this year we are making interest payments, so you will see debt increase a little bit, and then next year in fiscal year 27 we will start paying principal. And the tax rate will be, we will be able to put that into the tax rate next year. We're collecting taxes as usual, nothing unusual about that. We're on schedule. We have collected 39% of our levy versus 38% last year. So nothing unusual about that. Direct services continues to grow. We spent $12.9 million year to date versus $7.2 million last year. We can go over that in the direct services detail. Opioid expenses were almost 43,000. We still have 2.2 to spend. And Sendero high-risk claims advance is now $5.5 million. They have started repaying from the risk adjustment that they received. I believe we received $14 million in October. We received another $17.1 million in November. So that balance is down to 5.5. I believe they've paid that off in January. And we also, in the month of December, made a capital payment to them of $8 million. And so you will see our advance to Sendero in our long-term assets on the balance sheet increase by $8 million. Any questions about any of that?
Why don't you finish up and then we can
Sure.
entertain questions. Thank you.
So on the balance sheet, in the other receivables, on page 4, I just want to point out in the other receivables, that's where our Sendero receivable is. You can see it's gone down from the $37 million that it was last year down to $13 million. That's where that shows up. And then in long-term assets, a little bit further down on that page, Sendero paid in capital, you'll see that that increased by the $8 million. That's where that is recorded. And then on page 5, the next sheet, The next page, in liabilities, under the restricted or non-current liabilities, kind of in the middle, you'll see long-term debt service payable. That's where you'll see another 480.9 million show up. On to page 6. It's not, not on this one. There's nothing unusual about this. Our patient revenue is still coming in nicely. And you can see our uses of funds. You'll be able to see our opioid expense there. And then we did get the OCO grant, and so when we start spending on that, you'll be able to see that in that line, but we haven't spent any of that money yet. Healthcare delivery on page 8. I just want to point out in the purchase healthcare services on page 8, the top line, primary care. Right now, that is where our entire payment to CUC is being recorded. We are in the process of coming up with an allocation to, since they are billing us differently, we're paying them differently. We're coming up with a monthly allocation because we pay them for primary care, behavioral health, which is the MAP program, and then also a few specialties. So we will be allocating that out, and you'll be able to see that, I believe in January, we're gonna do that. And then on the CHIF, I just want to point out, just that last line under purchase healthcare services, they finally did, they have 2 contracts, one with Central Texas Food Bank and one with the Other Ones Foundation. Those are now active, and you will start seeing actuals, actual spend in that. And those are both for food insecurities. And then on page 9 is direct services in detail. Nothing really out of line on this page. And then on the specialty care is on page 10. I'm sorry, on page 11. And there's nothing really out of line on that either. If you have any questions about that, I need John to come up here and help me with that.
Does that conclude your presentation?
Yes.
Well, thank you, Nikki, appreciate it. Just really a quick comment before I open the floor. On page 25, if in the future, if you can designate where the payment is CUC, I know the primary care is, but just for folks who are not aware that primary care is through CUC, I think that distinction will be helpful.
I'm sorry, which page did you say?
Well, it's page 8.
Oh, okay.
I'm sorry, it's page 25 of the packet.
Okay.
So where you have specialty behavioral health and substance use, if you can put in a bracket CUC, primary care CUC, I think that would be helpful. That clear
Okay, so just so
distinction.
you know, that's not 100%
Whatever-
CUC.
Well, you can say, at least having that spell out, it will
Okay.
be helpful.
Okay.
And question that I had, lastly, on page 10, what is the in-kind expenses?
Those are the naloxone that we receive from, I can't remember the name of the organization that got the grant. But what we do is we ask for an order of naloxone, and they actually give it to us for free. We have to record that on our financials, so it's basically revenue and expense, and so that's what that is. It's free naloxone.
Also, the same thing, it's just for clarity, if you can just add what it is, a footnote, whatever the in-kind expense, just, I think for clear transparency, when anyone is looking at it, they're aware. So at this time, I'm gonna open the floor. So I will start with you, Manager Jefferson.
So I might need an orientation, just an understanding the financials, and if my questions would be better served at another time, I'm okay with that. So working from the back forward, the pages 9 and 10 that break down direct services, where do these, what is being captured here? Is this care and costs across the system? So central health, direct services, community care, else, others, integral care, I don't know what all is rolled into that. Where do these numbers, what do these numbers reflect?
So this is just central health. This is just our direct practice. And so the physicians and our co-hires, the UT, that we employ as employees are the only costs that are in here. So they're just central health employees, not CUC, nothing to do with Sendero. This is just central health costs. And for the most part, the main cost in these is FTEs.
And then, backing up, and this is something that could probably be better explained in a one-on-one, but, let's see, page 4 on the balance sheet. No, not that one. Yeah, the balance sheet where it says Sendero paid in capital. What is the capital?
So they're required to have certain capital requirements by TDI. And we have funded their capital requirements for them. And every year, they didn't last year, but we usually budget an amount to be able to give to them so that they can meet those capital requirements.
So perhaps, because we're short on time, Manager Jefferson, we can set up some time that I think they'll walk you through it. It might be very
That would be
helpful. So, Nikki, can you all set up a time, please, before the next Budget and Finance Committee meeting? Thank you. Is there any other pressing questions, quickly? Yes.
I have a real quick question, Nikki. I was just trying to figure out on slide 6, page 23, the other revenue source. I was just trying to figure out where the interest payments from our reserves are recognized on the balance sheet here.
It's
Is-
there. Oh, on the balance sheet or the,
On this statement, and is the whole other reserves interest payments back to us?
the other revenue, the 3 million that is this year, that is our interest on all of our cash that is in our reserves, in our, in reserve for capital.
Sure, all our investments.
All investments, all cash accounts except for the LPPF fund.
Right. Okay, thank you. I just wanted to make sure I knew what that was.
Okay, just any last questions?
One quick one.
Dr. Martin?
Yeah, thank you. I had a question about the opioid-related expenses. Does that balance carry over year to year, or it has to be spent yearly?
That carries over. So that is the entire amount that we still have left to spend.
Okay, thank you.
Okay, well, thank you so much, appreciate it. Now, moving on to agenda item number 3, we did 3, sorry. Agenda item 4, receive the December 2025 financial statements for community care health centers. Dr. Nick Yagoda will be presenting.
Good afternoon, managers. If we could go to the first slide. This should be very quick. We had a good month, and we'll have some explanations of why it was a good month. There we go. Next slide, please. Thank you. So in this first quarter, we ended with a $3.9 million surplus. That was as a result of a couple of surprising favorable conditions. The first was that we saw pharmacy margins actually trend more in our direction this year, showing improvement over the way we ended the last year. Additionally, at the time of the budget, we had established a Medicaid reimbursement rate that was subsequently increased twice in the 6 months between the budget being established and the kickoff of the calendar year. So that is also contributing to increased revenue, as well as wages running under budget because of our growth and need for recruiting what are expansion positions as well as open positions elsewhere. Next slide, please. The first quarter ended with a strong balance sheet. A couple takeaways are cash days on hand are hovering at 39. They were 40 last week, but still staying high. Last month was still staying high. Liabilities decreased as we are improving our timely payment to vendors, and our current ratio is now over 2.0, indicating a very strong cash position. If we could go to the next slide. This will be the last slide. Improvements in encounters over last year. This is also contributing to increased revenue. We have a 5% increase in encounters from first quarter of the prior year. Unduplicated patients have increased 6%. The utilization of our provider templates at the end of the day has also increased from 85% to 90%, so we're being much more efficient with our resources. And the percentage of patients who are at least 90% of their targeted encounters has jumped an additional 5% as well. So greater efficiency within the entire operation helping contribute to these increased revenue. We do have some headwinds. We have some vacancies that still exist at the end of the closeout of this month, but we are onboarding a number of providers in the next couple of months. And we do know that women's health and pediatric provider openings are affecting the substantial influence that Medicaid has on our revenue. So those remain important opportunities for us, but we're making very good headway in the first quarter. Thank you.
Thank you, Dr. Yagoda. Well, some good news, I guess, overall.
We'll take it.
Thank you for all your hard work, you and your team. Thank you all. Is there any questions to this item, Dr. Martin?
It's just educational.
Sure.
I'm sorry. Why do the HIV/AIDS encounters cost so much more?
They're funded through a different avenue through the Ryan White grants, and it allows us to have a much deeper care team where there's a deeper involvement of case management, behavioral health, and an assorted array of collaborative care team members. So it's a deeper bench than we have in general primary care.
Okay, thank you.
You're welcome.
Thank you. Any further questions? And I've been told Manager Motwani is online. Do you have any questions, Manager Motwani?
Thanks, Chairman Saif, I do. And congratulations, Dr. Yagoda, on, again, net positive news. I wanted to dig into some of the details. It seems like, and forgive me, I'm not able to see the presentation in front of me at the moment, but from what I heard, the surplus is due, or the positive variance, I guess, for the month is due to improved pharmaceutical margins, or pharmacy margins, rather, and improved, and then some savings due to vacancies versus projected expansions, and vacancies for existing positions and projected expansions. But I also heard that some of the revenue was, that also the net revenue increase was due to an increase in encounters. So it seems like maybe not directly inversely proportional, but some sort of inversely proportional relationship between providers who are able to deliver encounters being in place and encounters delivered would, there would be some relationship there that if we're getting savings from not having providers in seats, but we're also getting savings, or we're also improving net revenue as a result of encounters, there's some dissonance there. Is that able to be explained kind of is that nuance able to be explained here, kind of at a high level, or is it worth
Sure.
digging in more specifically?
Yeah, sure. So you're bringing up two concurrent effects. It is this last slide that shows that for every provider, we are seeing increased efficiency. We're getting more encounters per provider than we did last year. And so even in the face of vacancies, that increased efficiency, which translates over a much broader provider base, translates into increased revenue.
Okay, so would the notion be that if we had more providers in place, that those efficiencies, if they were to remain, would result in an overall even more dramatic potentially improvement in net revenue?
That is correct. This is Tara Trower, Deputy CEO. The under spend on wages is not actually something that we want to see, particularly around the providers, because for each provider that we have, there's additional revenue generation and additional access. And so that is, while it makes for a nice looking into the quarter, it is something that we want to push on. But to your point, Manager, that there would be additional revenue associated with each provider, and we would hope to continue the efficiency even as we add on more providers.
Thanks so much for that, and look forward to seeing you all in person shortly. Thanks, Chair.
Thank you, appreciate it. Thank you, Dr. Yagoda. Thank you, Tara. Really appreciate you. Okay, I don't see any further questions, so thank you all. I am going to move us on to agenda item 5. Discuss and provide guidance to staff on a policy related to Central Health's consideration of funding requests from community organizations. Dr. Pat Lee, Nakia Smith, and Perla Cavazos will be presenting. Managers, this is the first of it's going to be a conversation. We're not going to be expected to be drafting a policy at this point. We're just going to engage board members to see where their heads are in terms of funding or outside organizations, and this will not be the last time we will be presenting this item. So I just want to make sure that I heard from all of you, just to get a sense to help draft a future policy in place. So with that, I am gonna open the floor to Dr. Lee.
Thank you, Chairman Saitief. Our Chief Compliance Officer, Nakia Smith, is here with us virtually. The roads from Dallas are pretty icy this morning, so she's with us virtually. Just to get us started, we are aware that there's an opportunity as we prepare for this year's budget season to make sure we close some of the loops that were identified last year. We anticipate that, like last year, we may receive requests for funding from a number of our partners. We want to make sure there is a clear board policy in place to provide intent and guardrails that will allow us to do that in an orderly way. We also are listening carefully to some of the comments that we have heard from board managers where there's a role for board policy that perhaps there may be other board policies that we may want to put in place in advance of the start of the budget season. And so this is a good chance for us to trial out how we do some of that. And we know that there will be pairing of standard operating procedures at the staff level, but that they really should be linked to and refer to clear board policies. And so having Nakia here with us provides extra horsepower for us to do some of that review and to lift up. And between Nakia and Perla and our team, we expect to bring other policies forward to the board for consideration. So with that, today, as Chairman Saitief said, we're going to be looking for some key guidance, what's important from board members, and we'll use that as input to then put hopefully a mature draft before the board for consideration.
Thank you, Dr. Lee.
So with that, thank you, Chairman Saitief. Over to you, Perla.
Sure. Thank you, Pat. And yes, I want to also acknowledge Nakia Smith, our Chief Compliance Officer. We've had multiple conversations on this agenda item. I want to remind the committee that in December, the Bylaws and Policy Committee passed a motion directing staff to review existing policies and present a proposal for which policy should remain, which should become SOPs. proposed policies to be developed, including proposals from the Board of Managers and Mazars. Third, the committee directed staff to develop workflows that develop processes for developing these policies. And so Nakia and the compliance team is gathering a group of us to begin some of that work. And so she's leading that work around developing these uniform workflows, and I just want you to be aware that we're working on that. But in speaking with the chair earlier today, we want to proceed with having this conversation to get some guidance from this committee on this specific policy, which we know is very important. So with
Thank you,
that,
Perla.
with that, I want to reference the memo that was in your board packet. I drafted this memo back in October, and the memo frames some questions for you to consider to lead discussion and share. I don't know how much time you want to devote to this. I'm not going to go through all the questions, but I think just want to
So-
open it to feedback.
Yes, absolutely. I am going to open the floor. I'm going to start with Dr. Martin because I know he had some questions related to the fundings in the past. So I'm going to start with him, and then I'll go around the board to get a sense of where board members are with this. And I just want to remind folks beforehand is we ought to think and function as a high function organization and not to be really more responsive without having a clear strategy of where we're headed. So just those are just quite reminders of where we're at. So Dr. Martin, if you would want to give us your thoughts
You're
on
picking
this.
on me. I guess the issues on a sort of sophistry is sort of, we discuss our partners. I mean, what are we talking about, really? That to me is the essence of the question. I think our partners are the poor and those who serve the poor. And under that caveat, my fear what happened last year is it's the same thing. It's sort of, there's a prejudicial element to picking and choosing. And I'd like us to just be aware of that. So I think when we discuss partners, we need to really, that needs to come to the forefront as to what really is a partner. Versus a philanthropy.
Thank you for that. Dr. Brinson,
Well, I don't have any questions.
do you have any comments related to
I
this?
think that these are very good questions, and I think that we should have our next meeting and answer some of these questions with each other and see which direction we go.
Thank you, appreciate that. Manager May? Microphone, please.
I just have two comments, but, just things to consider, but we're really not working on the policy today at this point, right?
Correct.
So, let me just throw a couple of things out. Because of the nature of funding, as we know is happening with respect to all the federal and state programs, we know there's a lot of cuts. We know that a lot of our trusted community partners are coming to us for help, to help them complete programming or get them through, a period of programming and time period for their next budgets. I think, though, we're gonna get to a point where we potentially will be in a situation where we cannot serve or provide funding to every ask that we get. And so I want us to consider, and I'm just throwing this out, I want us to consider, when we have our discussion, whether or not we want to consider adding a limitation to the number of renewals, for example, that an organization may get. And I don't know, I don't have any numbers, I'm just throwing these questions out. And then do we want to have any roll-off periods? I'm going to throw this out just as an example, but it's not a real example. Say, for example, we've been funding somebody for 5 years steady, and you know, we've got other needs that are coming up. Do we want to consider having them roll off to a period of time where, you know, they take a break from funding from us and then we reconsider them again? Again, I'm just throwing some stuff out. I don't have any ideas about it, other than I'm just more concerned about the need growing for us to continue to expand the number of partners that we have. Not saying that the needs are not important, but I also want to believe that our resources are also finite. I mean, at some point, we've got to be able to put some kind of a limit on it. That's my comment. Thank you.
Thank you. Chair Geronimo. Chair Rodriguez, sorry.
Well, just to continue, I think with what Manager May has said, I think it's important to have guardrails, and it's very clear that Central Health is a hospital district, it is a healthcare district, it is a governmental entity. What it is not is a philanthropic organization. So I think it's important to make sure that we're clarifying that. I think the other part is, just to say up front, I am not a very big fan of carryovers and budgets from one fiscal year to the other, but I think it's important in this aspect to make sure that whatever that budget item is integrated or that decision is, so we're not making decisions halfway through the year, a quarter, and all of a sudden there's a special request, that there is a budget, a set budget. And then the last thing I'll mention is a real need to think about, I think at all of board meetings, and ask the question at the end, it's like, have our values aligned to our actions today? And I think it's really important to understand how whatever requests you're considering are aligning to our mission, vision, values, our strategic plan, our community health needs assessment, and whatever district scorecard or performance goals. In other words, it should be an extension, it should accelerate, it should be leveraging what we're already doing as a partner, as an extension. And I think there's more discussion to have, but I think that's important to at least have a direction about what it is not, and then where we're trying to align here in our investments around this budget line item.
Thank you. Manager Kitchen.
Yes, a couple of comments for consideration by the board in the policy. Most of them are aligned, but a couple of different subject matters. So first, for example, I wouldn't limit this policy to just during the budget process. I think it needs to allow for the fact of unusual circumstances where there may be cuts. So for example, the federal government recently just pulled all this funding, the SAMHSA funding, then they allowed it back. But we could be in a situation in the middle of a budget year that there's something we choose to react to. So I think that the policy needs to, not as a usual course, but, in unusual circumstances. So I think that should allow for that. The second thing I would say is, the bottom line for me is that when we fund anything, it needs to align with our strategic plan and our strategic goals. So, and it also needs to consider the impact on our patients. And so to me, it's almost the same criteria that we use during our regular budget process to decide what services we're going to fund. And from a board perspective, I'm not as interested in the individual entities. What I'm interested in is the services that we're going to fund. And I want to know if we're facing a cut in services to our patients, or if there are additional services that we've identified that we want to provide that aligns with our strategic plan. So in other words, if you get a request, I would expect the staff to evaluate the request against those kinds of criteria, and then I would want a recommendation, from staff. So that's the kind of thing that I'd be thinking of. The other thoughts that I have is the other sort of value that we've talked about, and we'll get more clarity on as we proceed through the strategic planning process, is that our partners are important to us so that we're not duplicating services. So one of the things we need to think about is that partner the partner that we want to provide the services for our patients? as opposed to something that we should be doing ourselves. So to me, that's always a question when we fund anything, and it's the same thing with anybody bringing an ask to us. And then the final thing is transparency to the board. I really think it's important for the staff to do all the vetting and evaluation and make recommendations to us. But we are responsible for the use of tax dollars. So in that sense, we have a responsibility to the community to be responsive. So so we need to know if requests are coming to us, and many of which would be handled by the staff, but we need that transparency in order to understand what's going on. Because again, at the end of the day, the board is responsible for the use of tax dollars in a manner that's transparent to the community. So those are just a couple of the kinds of things that Chair.
Thank you.
Yeah.
Appreciate it. Manager Jefferson?
It would be helpful for, I guess this is going to be presented again, to have an idea of the current organizations that have received funding. I'm not sure if I understand the range of organizations we're talking about. So just, that would be helpful, his background information. And I agree with all the comments that I've heard so far. I would emphasize, though, that it's good to be transparent with the board on requests that have been disqualified or rejected. If there's like a standard that's a board policy that's administered at the staff level, just for transparency purposes, to know that. Also, I'm not sure, because I don't understand the types of funding that we're talking about and amounts. It would be good to know if we're talking about something above a certain amount in the aggregate over the course of a fiscal year. That would be helpful to know. Whether there's a place for there being more of a structured program around it, so that folks know this isn't something for which I can make a request, grant request or whatever, or is it just purely on an ad hoc or a combination of the two? But I think that would be helpful.
Thank you for that. Appreciate it. Is Manager Milani on?
Yeah, he is. Thank you so much. And
Do you have any comments?
Yes, the first is I don't always refer to myself in the third person. The second is I apologize for not having my camera on. I'm en route. I'll surely turn it on if I were to vote. And then finally, I appreciate this discussion. So many of the thoughtful comments have already instigated some, I think, pretty helpful thoughts on my side. At the outset, I see kind of two delineations that are important. The first, is whether we're contracting for services or whether we are funding a philanthropic cause. I think those two demarcations are important to be clarified. Secondly, I think these further dimensions might add some clarity, and I think that when we're looking at this, we need to look at it in three categories: mission critical, mission enabling, and mission adjacent. And I think right off the bat, mission adjacent is, that's funding a philanthropic cause. But mission critical is a no-brainer that it's part of our strategic plan, and it's a requisite service that needs to be contracted and paid for in order to advance our strategic plan. I think mission enabling is maybe likened to the notion of the analog might be without, like a continuum of care, but I think a simple analog would be like without roads you shouldn't manufacture cars, right? That kind of thing. And so when we're talking about those philanthropic causes, that would be something I think that should be the purview of the philanthropic organization, i.e. the foundation potentially. And then when we're talking about the first two, mission critical and mission enabling, I would see those as areas that would be contracted, again, by means of, first of all, policies, standard operating procedures, as well as criteria qualifying for mission critical or mission adjacent. When it comes to, I also really liked Vice Chair May's suggestion about number of renewals or maybe built-in sunsets. I think that might be most applicable in the philanthropic sense. We could probably bring that to the philanthropy committee when discussing possibly foundation work. And that said, another consideration, I think, when we're contracting with organizations, is what percentage of their overall revenue is the central health contract. And, just making sure that we have some predetermined dimensions there of what we're comfortable with and or not, and how we would proceed through that lens. Thank you all so much for this discussion.
Thank you and drive safely.
I have one more comment.
Quickly?
Yeah, very, very quick.
Okay.
I just want to say, thank you, Manager Motwani, for that kind of separation. I think that's important. And then I would just want to say, I want to comment that, just for me personally, I would be very, I would only want to think in terms of limited renewals in the philanthropic context. I would not want to think about that in the contracting context. So I just want to make that point. I don't think it makes sense for us if we're trying to provide services. I also think the percentage that we are of someone's budget is an awareness thing. I don't think it should be a determining criteria if it's a contracting thing. It might be a determining criteria for me if it's philanthropic. So I just wanted to add
Thank
that
you
to
for
that.
those comments. This is a really good conversation that we've had. I think the first of its kind. Perla and your team, if it's possible that you can summarize all these comments, and then at the next few weeks, if you can share those with us, I think that would be helpful as we're preparing for a policy in this regards. With that, thank you, and thank you, Nakia. I hope you're home well and safe and
Thank you.
warm. And thank you, Perla, and thank you, Dr. Lee, for this. Now, I am going to move us on to item 6, our last item, actually almost, before we adjourn, which will be in closed session. We will be discussing item number 6, where so I announce that the committee is convening closed session to discuss agenda item 6, receive and discuss financial and operational updates from Sendera Health Plans. It's under Texas Government Code 551.05, Governing Board of Certain Providers of Healthcare Services, and or Texas Government Code 551.071, consultation with attorney. So at this time, we are going to close session, and it is January 28th, and it's 4:56 p.m. Thank you. And for the public, we don't anticipate this to be a very long agenda item, hopefully maximum 15 minutes or so. Thank you. So, we are back to open session. We discussed agenda item 6. Oh, actually, we're back. It's January 28th, 2026, and it's 5:13 p.m. We discussed agenda item 6, and there's no motion necessary for that item. Now proceeding to agenda item 7, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee meeting is tentatively scheduled for Wednesday, February 25th, 2026 at, why is it 3:30 p.m.? So usually they're at 4 p.m. at the Central Health, unless it's otherwise, at Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. So we have a motion and a second. Any discussion? All in favor? Aye. Meeting adjourned and on time. There you go.
Good evening. Today is January 28, 2026 at 5:14 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. As a reminder, some of our board members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So we will now proceed to public communication. Yeah, and I'd like to announce that in order to make it more accessible to community members, we will now hold a public communication for the Budget and Finance Committee and the Board of Managers meetings.
Chair, may I ask a
Sure.
question? I don't know what we did, but it's not 5:30 yet. Can we start taking it before 5:30?
Got it. So we'll start public comment at 5:30, so I'm gonna proceed to the consent agenda and ask if there is a motion.
Can I move that the board approve consent agenda items C1 through C3.
I second.
Okay, there being a motion and a second to approve the consent agenda items C1 through C3, all those in favor?
Aye.
Aye. The motion passes by unanimous consent. We will, do we want to take a pause for the, let me see.
Chair,
Yeah.
I'm curious if we're hoping to make sure public communication is accessible at 5:30. If there are folks already here, if we were to begin, do you reckon that would take us into 5:30? Do we know how many folks are here, or
They may want all of them.
to begin at the same
Yeah,
time? Okay.
Yeah. Chair, maybe there's an item you can take up.
Yeah, can we,
I feel like I could share the CEO update component,
yeah,
if that's helpful, Chair.
I'm sorry,
I
Dr.
could share the CEO update component, just the sort of,
Sure.
oral update component.
Yeah,
But
but for the benefit of the public, I just want to clarify that we will wait till 5:30 for the public comments, and in the meantime, we'll take up items that we can take in turn. And what I'll do now is proceed to the the CEO report, and I know we're gonna pause on item 1, but we can move on to the second one until we get to 5:30. Dr. Lee, sorry.
Thank you so much, Chair and managers. So in your packet on page 79, you will see sort of a bulleted list of the topics that I will be covering through. So 79 of the main board packet. And I just wanted to thank you so much, Chair, for this opportunity to share these opening remarks. I want to begin by just thanking and acknowledging our outgoing chair, immediate past chair, Ann Kitchen, and our outgoing vice chair, Dr. Cynthia Brinson, for your tremendous leadership and efforts to us. Congratulations to Treasurer Dr. Musaitif and Secretary Dr. Martin for continuing your roles, and a huge welcome to our new chair, Aaron Rodriguez, and our new vice chair, Lisa May. We are delighted and look forward to working with you. Really want to thank and acknowledge also the leadership of Chair Rodriguez as he has been talking about as a team of 10 approach in the coming year. We're excited about that, and I'm honored to learn from and work with this visionary board. What I want to do now is share a high-level summary of some major updates from across the organization over the last 30 days. And at the direction of our chair and vice chair, going forward, I will plan to provide this brief, comprehensive update of the recent month, and really aiming these remarks also to our listening public, to provide a clear view of kind of what's happened in the last month. So just coming through briefly, starting at the top, at the January 14th Strategic Planning Committee, the committee agreed on final language for our Strategic Transformation Resolution. We will be taking up this final resolution later today for approval, which will formally launch our strategic planning process. I want to thank all of our board managers for your due diligence in getting the language right. We are now positioned to move into getting this hard work done on the strategic planning and realizing our ambitious vision for the future. Next, as the board is aware, this Saturday, the Central Health and Community Care Boards will hold a joint retreat with the goal of sharing essential information and gaining greater understanding of each other's respective goals and priorities. And I'm looking forward to presenting jointly with Dr. Nick Yagoda on our shared vision for the future of our work, and really appreciate the time that all of you are taking to be with us this coming Saturday. Last month, with the approval of both this board and the Travis County Commissioners Court, Central Health issued $248.9 million in debt to advance three key priorities: to help acquire our Northview campus, which will expand access to care in one of our highest need areas, to purchase our Promontory Point campus, which will provide a hub for clinical support services and also help us achieve our long-term cost savings goal through ownership rather than leasing, and to help support the financing and development of our new healthcare facilities at Hancock and at Colony Park, which will also allow us to preserve cash reserves for future healthcare service needs. This debt issuance will help preserve our long-term ability to provide essential healthcare services for our patients, even as the broader funding environment remains volatile. Next, I'd like to share a few clinical and coverage updates. I want to kick things off with a big win. As the board just heard, this quarter we've seen enrollment in Sendero coverage shoot way up, more than surpassing our year-long goal of a 5% increase in just this first quarter alone. So kudos to the Sendero team. In early January, we hosted an open house for current and prospective Central Health System contractors. While this meeting was designed primarily as an information sharing on business opportunities, many of the attendees expressed strong interest in supporting our mission more deeply. This was a welcome surprise and a positive one, so we're following up with them to ask how we can tap into their networks and amplify information about Central Health, the message that access improves affordability, which improves essential value in our community. It's very well received. They wanted to help us amplify that. Next, our naloxone community distribution and overdose prevention program continues to expand rapidly, helping to save lives across Travis County. Over the last 3 months, our team distributed more than 3,000 life-saving naloxone doses across over 25 sites. This is an important milestone in our efforts to prevent opioid overdoses in our community. As the program grows, we are also launching a site naloxone champion training for staff, and we continue to pair every new vending machine placement with formal overdose prevention education in close partnership with UT's College of Pharmacy. In the second quarter of FY26, so coming up, we're excited to expand this training to administrative and leadership teams at our airport office. Next, we are quickly developing several new clinical programs in our practice, including an occupational therapy and long-term chronic disease management, just continuing to broaden and deepen our current offerings. This month, we celebrated the graduation of our very first cohort of community health worker apprentices. 5 students who completed a 13-week learn and earn program, so able to earn a full salary while they're learning, which is very important to make this accessible to our community. With rotations across multiple central health teams, we're in the process of looking for opportunities to provide career options for those individuals in our system. Our next cohort begins in early February for the community health worker program. We also just launched the 6th cohort of our medical assistant apprenticeship program, similarly a learn and earn program that now has 34 graduates, many of whom have been hired within our system. We remain extremely grateful to the Austin Community College for their partnership in making this program possible through their continued partnership. And finally, a few updates related to our workforce and community engagement. We have officially rolled out our new leadership development program, Guide with Love, which centers around our core leadership values of growth, unity, innovation, direction, and empowerment. And we're rolling this out to leaders across the enterprise. We began by piloting with the executive leadership team and top leaders from across the system at Central Health, CommUnityCare, and Sendero. And we are now training weekly cohorts of leaders throughout the system that will run through May. Meanwhile, at our airport office, we have begun using a new shared visual management and working space. So those of you who are visiting us will see an open mission control type area where we have agreed to gather as a system executive team 1 day a week to more easily coordinate with each other, align our teams, see the relevant information, and make decisions together, helping us drive toward even greater leadership collaboration across the board. Next, while artificial intelligence tools are already in use across our organization as they are around our world, we are developing a system-wide framework to ensure disciplined AI tool selection and governance, to ensure consistency, establish appropriate guardrails, maintain alignment with our mission and values, while still making sure that we achieve the important gains in patient care and team efficiency that are available within safeguards and regulatory obligations. Just before the holidays, we hosted UMC Lubbock CEO Mark Funderburk for a learning session, who really shared incredibly helpful insights across UMC Lubbock's cultural transformation journey and strategic success in their market over the last 25 years. His insights reinforced how a strong culture of service improves employee experience, patient care, community trust, people choosing to access the service, and ultimately the financial health of the system. We are all looking forward to continuing the conversation with Mark and his team as we understand our own path forward and build our own culture rooted in purpose and, of course, centered on our patients. This month, we launched our system-wide Women's Community of Belonging group, which provides a dedicated space for women across our system to connect and invest in their professional growth together. In the second quarter, we'll expand these opportunities with the launch of a Parents and Caregivers community group in February. Prior to the holidays, we delivered 2 presentations to the Travis County Commissioners Court, 1 quarterly update, and a joint presentation with CommUnityCare and Integral Care focused on our coordinated behavioral health strategy. Both were very well received, signaling a high degree of trust in our work from the court, which we are deeply grateful for. We look forward to similar engagement with the Austin City Council when we present to them in early March. And finally, this month, I'm thrilled to join our board chair, Rodriguez, as a member of the Austin Area Research Organization, or ARRO, opening new opportunities to engage with influential thought leaders in the Austin community and elevate Central Health's profile. This builds on recent conversations we've had with the Downtown Austin Alliance, the Meredith Family Interest, and others, where early discussions around potential philanthropic opportunities are underway. We will keep the board informed as these conversations progress. And finally, before we close, if we have time before 5:30, I'd like to share a brief mission moment featuring one of the patients that we serve through our partnership with the Health Alliance for Austin Musicians, Kelsey Creek. Kelsey thought affordable health care didn't exist until she found him and got coverage through Sendero. Her story highlights the importance of our work in providing both crisis care and peace of mind for so many of our residents. It's a reminder of how our work helps make life in Travis County more affordable and for so many, and in turn keeps our community so vibrant. So with that, let's roll the video. Thank you.
Has always been like my outlet, I guess. I've always kind of felt like I didn't really have a way to express to people how I was feeling, and I always felt very reserved on talking about my emotions. Whereas with music, it's so intimate and it's so for me that I could just pour everything out into it, and then when I feel comfortable enough, I share it with other people. Majority of the reason why I stay in Austin is because of the access to healthcare. No lie, because I could not afford to live out here. I couldn't, you know what I'm saying? Like I wouldn't be able to do anything off of my income. But there's so many programs that like, kind of umbrellaing under HAM and like foundation communities that help support, people in my tax bracket and in my profession and stuff. So yeah, HAM was super impactful in the way that like, coming from not having health insurance to like finally having health insurance, and then also having people that help you navigate health insurance, because like it can get so confusing, and they even tell you like when to re-enroll. I'm like, oh my god, because I would have forgot. Like they're just like you really feel like they care about you, which I think is something that I don't know, I feel like a lot of people in my profession, we just feel like people don't care. Don't care. We're always in the background, or like, like you live your life in so many like highs and lows. And so like having somebody like genuinely care about you and care about your health and how you're doing and stuff, and want to see you like be healthier and more successful, like I think, was like super impactful, and literally the only reason why I stay here in Austin.
Thank you, Dr. Lee. Members, do you have any questions? I know we have like a minute before we start a public comment. Okay. If not, I'm going to proceed to the public communication. It is now 5:30, and I'd like to announce that in order to make it more accessible to community members, we're now going to hold the public communication for the Budget and Finance Committee and the Board of Managers meeting.
Thank you, Chair. I will now call up, when called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we'll allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. I'll be calling everybody in the order that I received. We received 16 public comments for this evening's public communication portion. First up, I have Mr. Larry Wallace Sr., who's here in person. Thank you, Mr. Wallace. And you can just press that button in front of you.
Thank you. My name is Larry Wallace Sr., and I am here representing Commissioner Trevillion's Precinct 1 Health Advisory Council. And what I wanted to do today was speak in terms of your strategic plan, that we had an opportunity to meet with Dr. Lee and his team last Friday, and they shared the strategies and what's being planned. And so I think it's called the Health System Transformation Strategic Plan or something similar to that. And so we learned some of the details about what's planned by Dr. Lee and this board. And we just want to applaud Dr. Lee and the board for your vision to really reach out. And the one area that I will briefly talk about is under Section D, where it states transformation cannot happen in isolation. The CEO shall engage key partners, including Integral Care, University of Texas, and others, in order to gain input. And so for me and for our team, what really matters is the fact that there is time to receive input on the process, to be a part of program design, implementation, and measurement for success. So we're just pleased to be with you, and we walk this journey with you because we know that it's not easy. You have tremendous demands placed on you as a board, but we want you to know that we stand as advocates. We want to be a voice in the community to represent you and your purpose. And so that's basically all I wanted to say tonight from Commissioner Trevelyan and our team. So thank you very much.
Thank you, Mr. Wallace. Up next, we have Frank, who's joining us here in person. Thank you, Frank. You have 3 minutes.
Hello, everybody. Hi, good evening. My name is Frank Bowers. I am a resident at 1016 Willow Street, so 2 doors down over here, and a homeowner there, and I live with my wife, Monica. She's actually a physician at a community care facility here in Austin, and we have a 10-month-old daughter. Wanted to raise something, learned recently and kind of understood that Central Health allows camping at at this site here, and wanted to bring this up. It's a sensitive issue. We have had serious safety and serious health and hazard concerns because of it on a weekly basis, borderline daily. We have people coming and using the restroom on the backside of our property here. We have had there's numerous just very intense fights that happen behind there. And the reason I want to bring this up is, my wife and I, we are so committed to the mission of Central Health. I mean, this is what my wife does every single day. And with your focus on taking care on the clinical side of Austin, we are 100% supportive of that. However, if you allow camping on here, that's not your mission. Frankly, you're not equipped in that position to take care of the complex needs of people under those situations. And so we're asking for you all to seriously consider stop allowing camping. And I'll leave you with one quick story. 7:45 was giving my daughter a bottle a couple of months ago, and someone put a wooden crate up against our 8-foot fence, climbed the fence, didn't have a shirt on, came up to the back window. And these are the kind of things that we had this lived experience on our side. And so I want to make you all aware of this and see if you would consider to not allow camping on your site during the off hours. So, it is, again, we are all for your mission and we believe in what you all do. But this is causing real harm to your neighbors and the community here. So, that's all I have time. So appreciate it. Thank you for the ability to talk tonight. So thanks.
Thank you, Frank. Up next, we have Jennifer, who's joining us online. Jennifer, can you unmute?
We got it.
Perfect.
Hi, Yesenia, thank you.
Thank
for having
you.
us speak to you this afternoon. We live just about 3 blocks away. We're right next to the Sanchez School on Garden Street. And I have 3 granddaughters, all of whom are avid readers. Even the little one loves her books. And I am frankly petrified and don't take my children to the Terrazas Library. I don't do my grandbabies. I'm scared, and I'm generally not scared. I'm an ex-nurse, and it's pretty out of control over there right now. Particularly this weekend, I know, again, sensitive subject. However, people are camping. People have been in front of the library around the brickwork now for a week in what is a semi-permanent campsite. The trash is very deep in certain areas. There's broken glass. My husband and I did walk downtown about a week ago, and it was pretty scary, honestly. And there's lots of health and safety concerns. I don't bother to get into the weeds and look for things, but there's a lot of stuff that shouldn't be there. As a driver, I come through there, I'm dodging folks in the middle of the road. My car is banged if they don't like me, they yell at me if they don't like me, I don't know what the deal is, but it is, it's a scary situation. Our grandbabies may go to Sanchez, we're really having second thoughts about that. I feel as a taxpayer and as a resident, I should be able to enjoy my library. And it's not a safe place, I can't go there, and I can't take the grandbabies. It has gotten worse of late. When the construction started, it initially sort of backed off, and now we seem to have a new influx. More folks, a little bit more, it feels scarier, it feels a little more aggressive, I don't know what the difference is, but it is out of control, and I would like you guys to look seriously at what can be done on your end, and I know you can't work miracles, but if we all can pitch in, certainly I think camping should be out of the question. There are no sanitary facilities, nobody's using the bathroom, they're peeing in the streets, in the alleyways, and defecating where they can. It's not acceptable to me as a resident, and I'm dismayed. I mean, I should be able to take my grandchildren to the library. And I hear that Terrazos has a lovely children's section, but we wouldn't know. So, do you have anything to add? So, thank you for letting us talk, and thank you for listening, and I hope we can make some progress on what is becoming a truly unsafe situation.
Thank you, Royce and Jennifer. And I have this following statement from Giannis, who was not able to join us the very last minute. He says, I live just south of Cesar Chavez on Waller Street, and I've noticed the homeless situation get worse every year. I no longer feel safe walking around now. I often have to step over homeless people passing out in the middle of the sidewalk when walking somewhere nearby, get confronted by angry window washers every day when driving to I-35, often also having homeless walk out in the street in front of my car without paying any attention, or sitting in a chair in the middle of the road begging passerbys. I have packages occasionally get stolen too, but fortunately no vandalism yet anyway. My girlfriend absolutely refuses to walk anywhere, and she loves to walk when she feels safe. I really hope the city can find a way to address the situation and properly shelter and feed the homeless in a way that doesn't endanger the community around it. And up next, I have Emma.
Before you go to the next person, could you, just for the public record, give the first and last name of Giannis?
The first name is Giannis. Some residents have asked not to have last names, but I can definitely provide the list for you.
That would
if
be
that's
great.
possible.
That would be great, thank you.
I will provide the full list to the board. Up next, I have Emma, who's joining us online. Emma, are you able
She's
to
actually in
unmute?
person,
Oh,
Yesenia.
Emma's in person. Okay, perfect. Good to see you, Emma.
Good to see
You
you.
have 3 minutes. Thank you.
Okay.
And yes, the microphone is on.
Cool. Thank you so much. Good evening, Chair and members of the board. Thank you for the opportunity to speak today. My name is Emma Kenninger. I live in the East Cesar Chavez neighborhood. I just wanted to start by acknowledging that people camping on Central Hill's property are there because they lack safer options, and many are trying to meet basic needs, warmth, food, rest, in extremely difficult circumstances, and their safety and dignity matter, and we need to continue working to provide those services. But I'm here today because the current policy allowing overnight camping on the Central Health property is unintentionally creating escalating public safety risks, particularly related to unmanaged fires. I have personally witnessed and have heard from other neighbors multiple times that open fires are being built in and around camps. A lot of these fires are not contained or supervised. I've driven past many times at night and just seen an open flame sitting in the middle of an alleyway or in the middle of the street. And they're often fueled by wood from fences or trash or furniture, and sometimes used fuel to get it going, which makes sense. And I understand that these are being used for warmth and cooking, and those are all needs that need to be met. But in
a place where it's already so dry and there's already risk for fires to spread quickly, I think we really need to think about it and figure out how to manage that better. Emergency services are being called repeatedly to respond to these fires, and each of these responses pulls firefighters away from other emergencies. It's important to be clear about enforcement. APD has stated that when a landowner permits camping, trespassing laws and camping restrictions are not enforced. As a result, Central Health's decision to allow overnight camping removes effective mechanisms to prevent fires or be able to intervene in early stages before dangerous conditions arise. This is about recognizing that unmanaged camping with open fires and no fire control is unsafe for everyone involved. By discontinuing permission for overnight camping, Central Health would restore the ability for dangerous behavior, including open fires, to be addressed before someone is seriously injured or a fire spreads in the dead of night when no one is available to call for emergency services. I urge you to
30
work.
seconds.
Okay. I urge you to work with the city toward safer managed alternatives that provide shelter and services without putting unhoused populations' lives at risk or surrounding neighbors. Thank you so much for your time.
Thank you, Emma. Up next, we have Sandra. Thank
Hi,
you,
I'm
Sandra.
Sandy Boone. Is that the right Sandra that you've got? Sandra Boone?
Yes, correct.
I'm also a neighbor. I live a little farther down Willow, a little closer to Holly. And I'm really going to be very short, but just echo what other people have said today. The stories you'll hear today can be repeated similarly, triple-fold from other people in the neighborhood who've given up calling. There's an old saying that charity begins at home, which is, of course, was just to encourage people to be generous and care for those in their family and their community first. And as your business is community health, I would ask you to put community health in your own home, in your own neighborhood, in your own property right here first. And as you know, as community health professionals, when people don't feel safe in their own homes, when they're feeding their baby and strangers are at the back door, when fences are lit on fire, when trash and human feces and things are regularly found on their property, that creates an adverse health effect for this whole community. And this community is a family community. These homes have been here forever. They understand that the homeless population is a huge problem in Austin, and I think they've been very generous, but there are ways to do that without allowing camping basically in people's front and backyards and putting their health at risk. Thank you.
Thank you, Sandy. Up next, we have Colonel Lori Desiati. Are you able to unmute?
Hi, thank you. Can you hear me okay?
Yes, we can hear you. Thank you.
Hi, thank you. I was just asked to speak as a member of the community, or sorry, by the members of the community, just to have a slightly different angle. I'm just coming from the perspective of a preventive medicine physician and family practice physician. Definitely applaud the efforts of the clinic and the outreach that's done for the community. In preventive medicine, we do have a lot of attention spent at our conferences talking about these issues. And so, without getting into nitty gritty details in a limited period of time, obviously wanted to just make at least for the record, kind of make the statement that we know there are no actual cases of HIV being acquired by needles that are being left around over the 30-year history. There hasn't been a case because, of course, the blood usually needs to be fresh, and most community-based needle sticks are not fresh blood. But there have been a couple of instances, for example, of hepatitis B and hepatitis C that have been transmitted. And of course, we do have plenty of fecal oral pathogens that can be passed by fresh feces. I think that it's without further information, just the general public knowledge when they find out that the city has a leave-in-place policy for needles and species because of the biohazard of the fresh species, I think that's always a little surprising to them because, of course, intuitively to them, they don't know that it is not all that easy to acquire HIV from a needle stick. But as we can appreciate, it really only takes about one child getting stuck or one person who has to undergo prophylaxis, even if they don't end up infected, to cause sort of an additional, I guess, bias and to deepen those stereotypes that make the homeless unwanted instead of gaining, kind of the sympathy and the continued progression toward solutions. So I think that while infrequent, my understanding was there was an offer to do cleanup perhaps 1 or 2 times a month. And while we do know that, the cleanup, of course, is great, that's 28 days where fresh feces could be in the area around these residential units where children play, dig in the dirt, people garden, and these feces are just on the other side of the fence where they can get into the soil or wash in a storm and that kind of thing. So we do know that exposure is a real risk. Um, and so it's understandable why the residents have a fear of these things, even though at a medical level, we know that dry feces do not transmit and they aren't considered a biohazard. And we know that we won't get HIV, but there are other real risks. And those things are intuitively obvious to those who see needles
30
and
seconds.
fresh feces lying about. So I just would like to see us avoid exacerbating the public sentiment of discord with the unhoused community and try to work toward other solutions. But in the meantime, I would have to agree that this clinic is unique in being closely adjacent to residential properties and therefore at a higher risk than most of exposing the public to some of these hazards. And I guess with the last few seconds, I just say there is some evidence of positive services and outcomes when cleanups do occur, but a
Chair,
cleanup
that
of
is time.
feces and needles just exacerbates the problem without resolving the encampment issue. So you have to address both. Thank you.
Thank you. Up next, we have Robert. Thank you, Robert. You have 3 minutes.
Yes, my name is Robert Mendoza, and I lived in the community for over 50 years. And within those years, we've had no problems or any issues. But within the last 3 years, or 3 or 4 years, we've had people trying to break into our house, get into our yard. Also, we've got my wife being threatened by a person just because she opened the door. And again, I was born and raised in East Austin, and we never seen what we're seeing now. And I've been in education now for, I was in education for over 44 years. And I'm also very involved with the community for all my life. And again, why do we allow people to camp in the area? That it's city property, and it's putting us all in danger. And like I said, at our age, when we were young, we could protect ourselves or run. Now we're too old; we can't run or protect ourselves. So we need your help to not allow this encampment to happen around here. Thank you.
Thank you, Robert. Up next, we have Carveen. Carveen, are you here in person or online?
She's
Okay,
not
I don't.
here.
Okay, I don't see Carveen. Up next, we have Molly, who's joining us in person. Thank you, Molly. You have 3 minutes.
Hello, my name is Molly. I have been a resident of this neighborhood for 20 years, and my house is on the Willow Alley. And, I want to echo pretty much what everyone else is saying. Sorry, I have some stuff written down I gotta find. I just want to share some of my experiences regarding my personal safety. Last year, I was on Cesar Chavez walking my dog, and a man displaying disorganized behavior was coming from this area, going from west to east on Cesar Chavez. And I thought, I'm going to give him the whole sidewalk. And so I backed up against Flat Track's coffee shop, and he spotted me and lunged at me, and he had a long, sharp knife, and he swiped it at my neck and face. And if I hadn't backed up, I may not be here today. So that was very scary. The police were great. They arrested him, and he's now serving 3 years in the penitentiary for felony assault with a deadly weapon. Let's see, and last Monday, not this past Monday, but the Monday before on the 19th, my fence was purposely set afire, according to the firefighter, and I lost about 15, 18 feet of fence. And the wind was blowing, and if the contractor who was working on a property nearby hadn't run over to help me with my hose, I don't know if I would have a house. And the firefighter said that, this fire was raging, and when it was moving so fast that it could have taken out a chunk of the neighborhood. That's that one. And then the other one was last week also. My dog alerted me I was inside. It was dark out, and my dog was barking, and I just cracked open the door, and there was a man in my yard, and he says, "I want a cigarette." I'm not outside smoking. Why do you think, you can get a cigarette? Obviously he was in my yard for something else, I believe. So anyway, I do think that it's dangerous. I don't feel safe in my house or outside of my house. I, barely walk my dog. I always have my pepper spray. And this is, this all kind of became worse in the
30
past
seconds.
3 years. So, I think any small thing that can be done to, camping and the property, we got to find places for these people to be. I'm not without compassion for the unhoused, but the way things are now is very unsafe, I believe. Thank you.
Thank you, Molly. Up next, we have David. Thank you, David. You have 3 minutes.
Yes, my name is David Arroyo. I grew up in this neighborhood. However, I moved away for 40 years, living in Houston, working for ExxonMobil. And I moved back in 2018 and live in the house that I grew up in. But I just want to echo all the sentiments that have been said. The only difference I'm going to add to it is that it not only affects us as a neighborhood, it affects y'all. I have a picture of what your outside sign looks like with all the trash that was there yesterday morning. Okay? If you want this picture, I'll be glad to send it to anybody that wants to. If you want video of the homeless at night that have been by my house at 1401 East 2nd, that have thrown scooters, picked up my neighbor's groceries that have been delivered, and done other things, I'll be glad to send them to you. I have 8 security cameras that surround my house and have picked up some interesting stuff. There's one thing for being compassionate, but I think sometimes we get to a point where we're enabling. And I think that we need to follow the laws of banning camping that Austin, the city of Austin, has passed the citizens, and we should follow that. Thank you very much. Like I said, if y'all want the video or the picture, I'll be glad to send it to you.
Thank you, David. Up next, we have Tiago.
Can you hear me?
Yes, we can hear
Great.
you. Thank
Excellent.
you. You have 3 minutes.
Thank you. Well, hello. I'd like to thank everyone here for the opportunity to comment on this topic. To start, and apologies if this has already been said. There are many of people out there who are present here that aren't everyone. There are many neighbors who wanted to come but aren't able to because of the relatively early hours. For example, I work until 6 or 7 p.m. So if anything, those of us here today are only a fraction of those who would otherwise also have wanted to be here today and have a say. And I can say this because I'm one of the administrators of an email group of 269 nearby residents, most of whom, through messages and the various community activities that we have had, have wanted to express the following points that I will say. The main one is that we believe that Central Health should not, and by law cannot, allow camping and overnight stays on its property, it being city property. We believe that to be outside of its taxpayer-funded mission, and that by allowing camping, state law and city ordinances are being violated. Additionally, and to support this position, we recognize that as a health organization, a very noble one, this policy to allow homeless to sleep or camp on the property overnight might have originated from a very good sentiment, such as the modern version of the Hippocratic Oath, which advocates medical practitioners to cause no harm. However, as we've heard, the needles, the drugs, the detritus, the unhygienic conditions, and the property crimes, such as the many home intrusions, thefts, tire slashings, fires, etc., that you've heard about, and that have happened in the homes directly surrounding Central Health, are believed to have been directly a result of allowing homeless individuals to stay on their properties overnight, which means that we believe this policy is directly causing harm to everyone else around, and that by allowing overnight camping on its property, Central Health is causing harm to the very taxpayers that fund it. Overall, there is a general sentiment in the neighborhood that, and we kind of heard it a little bit today, that helping the homeless is not providing them with just enough to stay that way, such a place to camp on your property. That just helps perpetuate the condition, not help incentivize them out of it. Additionally, when emergency requires it, like the cold weather we've just been having, other organizations are able to mobilize vehicles to pick up those in a state of homelessness and take them to overnight shelters to keep them from freezing. This indicates to at least all of us here that there are means and alternatives when needed, and thus allowing homeless to remain on the property is not a otherwise we condemn them to die or just harm moral dilemma. We also do not expect Central Health to monitor and enforce a camping and overnight stay ban, should one exist, on its property. We are all here to help enforce it and can work with various authorities to help report it when it happens. And this is being coordinated by a group from the neighborhood, which Shannon Taylor, present here in person there, is representing. And lastly, I want to thank you again for allowing me and everyone else that couldn't make it here today to have this opportunity to have our voices heard. And I want to close here again by saying that allowing camping in this property, Central Health is causing harm to its tax-paying neighbors, and for this and all the other reasons just mentioned, we ask that you end that practice. Thank you.
Thank you, Tiago. Up next, we have Wendy. Hi, Wendy. You have 3 minutes.
Hello. Hi. Thanks for having me. So, like others, I'm here as a concerned citizen and to speak out against the overnight camping that you're allowing on your property. So, Shannon Taylor is my sister, and I have been coming to visit her at 1104 Willow for, I don't know when she bought the house, a decade or more, maybe ago. I now have a 7-year-old that, we regularly come down and, play around in the neighborhood. And I can tell you that we are not comfortable bringing our daughter around. And we ask that Central Health just obey and enforce the laws of Travis County and Austin. We as voters overwhelmingly approved or voted in favor of a camping ban, and we want you to honor that. We can't, it's unsanitary, as others have said. We can't use the back of her property, of my sister's property. We can't enter there. That is quote unquote the men's restroom at night, as homeless have said. It's gross with urine and feces. And that's really terrible environment for all the neighbors. And that's not something we want to expose our daughter to. And it's really changed over the years, and has become so much worse. And we feel that, by allowing this, Central Health is actively causing harm to the community and the neighborhood and, not doing any favors to the unhoused. We also feel that, you might recognize that there is, dangers with the unhoused community because you do employ private security during the daytime for the business hours, and make sure that your property is cleared of homeless during the day, but that same, security is not there at night for the neighbors. So clearly there is a risk that is recognized there and that we need to do something about. So all we're asking is that Central Health work within the law. You're not an approved homeless shelter, and then the camping is, it's illegal and it's causing harm. So we just request that Central Health issue a standing no trespassing or no camping approval with APD, or appoint an all hours contact that will enforce the trespassing ban after hours. So if a neighbor feels unsafe and calls APD, they're able to get, some help and some resolution. So we just want to feel safe and feel clean in the neighborhood and follow the laws. So thank you.
Thank you, Wendy. Up next, we have Bill. Thank you, Bill. You have 3 minutes.
I don't know where the voice is coming from, but thank you. And I'm glad to see some familiar faces on the board. Thank you. I'm Bill Hamilton. I am a 13-year homeowner on Garden Street, 2 or 3 blocks this way, less than 600 paces. And I registered to be representing or speaking as a member of the E. Cesar Chavez Neighborhood Planning Team, and otherwise known as a homeowners association. And so that's my capacity for being here tonight, other than someone that's happy that I found this neighborhood about 13 years ago. From a good neighbor perspective, I want to add one other sort of aspect of the conversation here about accommodations, if you will, for the unhoused or homeless, or camping as some folks have referred to it, is the proximity to Sanchez Elementary, which is a few blocks or streets over this way, that same 600 paces, which I walked on the way over here. And fortunately, in their new configuration, they've got more security for those 200 or 300 students, and that's obviously good for them. I think the conversation we're having here is suggesting that you take a look at your policies and practices in this area, and maybe to see to the extent that they're compatible with or not with the policies and practices of AISD. So we've kind of got the classic situation here of no good deed goes unpunished. We've got a unique situation where we've got competing public policy priorities for public health, public safety, and public education. So I will just leave you with those thoughts, and always thank you for your public service, and we would appreciate your consideration. And we're in the neighborhood, so if we need to follow up, you can find us. The lady who's talking knows where we are. So, thank you again.
Thank you, Bill. Up next, we have Andrea. And I got word that Carveen wasn't able to join us, so they will not be going. And lastly, after Andrea, I have Shannon.
My name is Andrea Hill. I've lived at the corner of Willow and San Marcos for over 30 years. In the last 2 years, I've had my car stolen, my house broken into 3 times, once in the middle of the night while I was in there sleeping. So this is not fun. Unlike most of my neighbors, I am a semi-retired criminal defense attorney. For years, we arrested people for camping. We arrested people for drug dealing in the parking lot like they're doing every single day. And we put them in jail. And then kind of misguided do-gooders decided that was a terrible idea. So the city rescinded it and said you could not arrest people just for trespassing and camping. Now, it's a shame. I don't want people to think I agree with people being in jail, because actually I tried to get them out of jail in my role. But sometimes when they're in jail, they connect with services. They get drug treatment. They get other services that are helpful when they're locked in jail, they are referred and hooked up with services. So being in jail is not the worst possible thing that could happen. I know that people think, because the city of Austin, in its misguided ideas a few years back, rescinded the camping ordinances and said you cannot be arrested for it, okay? But that was misguided, and now it's just mushroomed. It's way worse. I drove here, even though I live half a block away, because I don't want to walk through all these people coming and going. And I don't want them to see when I'm coming and going, so they'll see when my house is empty, because that is an issue. However, it's just ridiculous. And people seem to have the misguided idea that it's still illegal to arrest people for camping. That's not true. There was a citizens' referendum. The whole city of Austin, not just our neighborhood, voted and agreed that, yes, you can now still go back to arresting people for trespassing and camping. And we need to, because it's just mushrooming to an extreme degree. And also, this is where a lot of people exit to go downtown, people from out of town coming through here. And the first thing they see when they exit right there is all these homeless beggars, window washers, and all of that. It certainly gives a bad impression of Austin. But as far as public health, yes, I find syringes and everything else. It's not safe for the health of the homeless people, and it's certainly not safe for the health of the neighborhood. You know, used syringes are just not something you want to find in your front yard. And it's certainly not good for our mental health. The neighborhood is just up in arms about this, as you can see by all the people that have come here. And you know, you're supposed to be a health organization
30
promoting
seconds.
health. So let's promote the health of the neighborhood and everybody else by arresting people when they are here, arresting them for trespassing. Thank you.
Thank you, Andrea. Lastly, we have Shannon.
Hey there, I'm Shannon Taylor. Thank you for hearing me tonight. I'm one of your neighbors. I'm at actually directly next door to you, to this building, at 1104 Willow Street, and I've been there for 8 years, and I love it, and I adore this neighborhood. I have a lot of compassion for the unhoused folks in the neighborhood and a lot of support for your mission. And at the same time, we just have a really big problem on our hands. And I'm gonna start by saying that my driveway exits the alley right here next to this building, right? I work really hard. I own a business and I come home at night and I often can't get out of my car. And I can't get out of my car because I don't feel safe. And it's not because of folks at the library and it's not because of folks out in the streets. It's because of folks at Central Health. Here at this building, every night, there are folks acting aggressively and erratically, and not always. You know, when folks are sleeping, I'll get out of my car. But just like Andrea, then they see me coming and going, right? And then they're casing my house, and that doesn't feel safe. And sometimes they come up and bang on my car. They come up and yell at me. They get real aggressive. And what am I supposed to do? I have sat in my car for hours. And I've sent you guys videos of this. You guys have a Dropbox folder, right, of all my videos where I sit in the car and I'm like, look, it's 10:30. Look, it's midnight. I just drove around for an hour and I want to go to sleep because I got to work at 6 a.m., you know? So what I'm asking for is that Central Health would stop allowing camping here. I support your all's mission, and my understanding is that it's clinical and that you guys provide health services in a clinic setting. Maybe you do it out in the community, but you're not a homeless shelter. You've got a taxpayer-funded mission. To become a homeless shelter, there are protocols and legal hoops. There's a plan, right, that you have to put in place. And that's set by the Texas state law, right, and the City of Austin code. And so my understanding is y'all are operating outside of the law, and this should be fairly easy. We don't have to make a new law. We're just asking you guys to enforce the one that exists. And so if I come home at night right now and I feel unsafe, I can call APD. I call 911, they come out, and they look at me and they say, we can't help you. That guy right there that's acting erratically, that's doing drugs, Central Health's allowing it. And they won't give us a phone number to call at night, so there's nobody I can call, right? So I would ask, number one, give me a phone number, somebody I can call at night, the neighbors can call when we feel unsafe, because they've said, You guys have to be the ones to say, yes, we don't want trespassing, we don't want camping, so go ahead and usher them along. APD has told me that any organization like this can issue a like a standing no trespassing order. So y'all don't have to call, you don't have to be up at midnight when I'm up. But if you would support that, then APD can do their job. And that's what we're asking for, right? As people have said, that's what the
30
voters
seconds.
have all asked for. So I know what y'all are doing comes with a good heart, and we all have it, but the spillover effects into the community, the feces that's piling up on my property, that's not always dry, sometimes it's wet and I step in it, that my sister won't come over and bring my favorite niece, you know? Oh, I hope none of my other nieces hear that, but you know, I'm out there gardening and I'm worried. I don't know what PPE and what protective stuff I should wear, and nobody's cleaning up the feces and the needles. And then I have an Easter egg hunt for kids, and then I'm worried, are they gonna find a needle? I mean, can you imagine? That is
Yes,
directly
time.
caused by camping here at this building. That's all. Thank you.
Thank you.
Thank you, Shannon. And Chair, this concludes this portion of public communication. Thank you.
Thank you all for your comments. Members, I just want to remind you that in your packages, you were given a copy of the Isa Chavez Neighborhood Community Homeless Task Force letter for your review. And I'd like to move to our regular agenda item, back to number 1, the CO report on item number 1, because I believe our CO report contains some information that's responsive to some of the comments raised this evening. And then after the response, we'll have just one more comment, and then we'll go into executive session for agenda item 8, just as a preview. Dr. Lee?
I'm just going to move up here so it's easier for me to see and address our neighbors. And I just want to begin by thanking all of you for coming tonight to share your concerns with us about what's happening in the neighborhood. Thank you, Frank, Jennifer, Royce, Giannis, Emma, Sandy, Lori, Robert, Molly, David, Tiago, Wendy, Bill, Andrea, and Shannon. Many of you have also been in touch with members of our team. Thank you for that continued dialogue. Please know that I hear you. We hear you. We take your concerns seriously. We hear the frustration and fear that you're sharing with us, and it matters. This is your neighborhood and ours, and you deserve to feel safe. You deserve to feel supported. And for our board's awareness, as Chair Rodriguez had shared, we received a letter this morning from the Neighbor Association, which you have in front of you. And while we received this letter just a few hours ago, it was really important. And so we rallied our team to try and provide at least an initial response to the 4 important points that you raised. So I'll offer that initial response, and we'll love to continue the dialogue. So one request is to improve interagency coordination. Yes. Central Health works with all of the partners named in the letter and more, including Austin EMS and Integral Care. And on this issue specifically, we have been in contact with the City of Austin Homeless Strategy Office, with the Austin Public Library, with City Councilmember Velasquez's office to coordinate a mitigation plan so that we can begin to respond to our neighbors. Those conversations are ongoing as we work to find solutions together. And if any of you or other neighbors who couldn't be here tonight think it would be beneficial, we would like to convene a working meeting with our partners and you, including the City of Austin, to clearly identify the roles that each of our organizations can play and practical actions we can take together. Another key request is to designate a central health point of contact that you or any of your colleagues and neighbors can be in ongoing dialogue with. As I think Bill pointed out, the ethereal voice that you heard is Yesenia Ramos, who is our community engagement manager and is wonderful for those who know her directly. So Yesenia will remain our point of contact, supported by our whole team. She's already communicating, I believe, with members of our neighborhood about this issue, and will continue to act as our liaison as we listen, as we work towards solutions that balance access to health care for people who are unhoused and the safety of our neighbors and neighborhood. Third, in this letter, residents also make a request to extend security and enforcement beyond working hours at the Central Health Office. We are already working with our security company to talk about extending those hours later into the evenings so we can have a more robust presence at our facility. we don't have that answer yet. It's short notice, but we'll report back to you on that. And then finally, as you have all eloquently stated, there is a request that we enforce the standing trespass agreement with APD. And I do need to acknowledge your top request is very important and also the most challenging and complex. As several of you have referenced, we know at Central Health that we exist to help people in our community who are most at risk. That is our mission. No matter what solution we pursue, we believe it's important to do no harm. That includes the people that we serve, and it includes the neighborhood and the neighbors where we serve them. As you all know and have referenced, this challenge is part of a larger challenge that we are dealing with in our community that does need a community-wide response. That's not to minimize, but we appreciate the complexity of these issues. And along with our Central Health team and our partners, I pledge to discuss your request seriously in coordination with the Austin Public Library, the APD, the City of Austin Homeless Strategy Office, and see if we can come up with a reasonable, comprehensive solution that respects doing no harm to all of the people involved here. A final note, we can do what we do well, which is to provide services. So we are already in process and committed to piloting regular after-hours outreach at this location, led by our mobile bridge team. As many of you are aware, we provide these services and outreach all around our great county, and so we will provide that here for those who are open to it, to connect people experiencing homelessness to housing, healthcare, and support services. And as we review the results of the pilot, we will figure out how to offer this on a consistent basis. We know that's not the solution, the comprehensive solution, but it's part of it. It's also what we do best, so we'll at least start there. And again, I just want to thank you for being here. Please know that we hear you. It matters. You matter. And we are committed to working with you going forward in a humane and a lawful and effective way. So thank you so much.
Dr. Lee, thank you very much. I would encourage members, if you all have clarification questions, to follow up with Dr. Lee, as we're not posted for this item, so we can't have discussions, although I think, David, we're allowed to ask clarification questions.
My clarification question is for you, Chair, and whether or not this can be, well, first of all, whether this qualifies as a clarification question, and secondly, if so, the question is, whether we can add this to a future agenda item at the next board meeting.
I think we'll take that into consideration in our executive session, in our executive committee meeting, but thank you for that.
Thank you.
Chair?
Yes, yeah.
Do you want to go? Do you want to go first?
Doesn't matter, you can go.
Okay. Chair, I would also echo that request of Manager Motwani. I think if we could have an agenda item, and I will leave it to the chair's discretion whether you want to do that executive committee, which all of our board members are, can attend, or if you want to make it an item. So, and then I also have a few suggestions that I will talk with Dr. Lee about.
Thank you.
Well, I concur. Thank you all too who came before us. We hear you, and I'm deeply sorry what you have to deal with on a daily, ongoing issue. Point of clarification, Dr. Lee. For item number 2, what is the expectations in terms of, because I know several wanted a contact number, but also in terms of the time, there may be late calls. So is the expectation that this individual will pick up those calls? So just further clarification on the expectations from both staff and community, because I am not sure if this individual will be probably able to pick up a call at 2 a.m. or later in the depending on the issue. So if you can add further clarification on that, thank you. And I also concur with my board members to bring this up to a further next agenda item. Thank you.
Thank you, Dr. Mercedes. I think that's a good point. Yesenia Ramos also needs to sleep at night, so we will get back to the neighbors with something reasonable and make sure that we are accessible. So thank you for that clarification.
Thank you, Dr. Lee. Members, we're gonna move to the executive session for agenda item 8, and so I'm gonna use some language, but before that, I just wanna share, managers, that since this is our first regular board meeting for the new year, and with some new executive board officers, I'd like to add to Dr. Lee's, I'd like to take the opportunity to add Dr. Lee to what Dr. Lee was saying, to thank our former Chair Kitchen and Vice Chair Brinson for their service. Central Health tackled many challenges during their tenure, but their steady leadership kept the district on track moving forward. And I also want to welcome our continuing officers, Dr. Manuel Martin, our secretary, and Maram Busaitif, our treasurer, and thank them for their willingness to continue serving in those roles. And our new vice chair, Elisa May, and myself serving as chair. We'll work with our fellow board members and Central Health staff to build upon the foundation already set and continue to move Central Health forward in its mission to provide quality care for our most vulnerable populations. We're now going to proceed with the executive session. I announce that the board is convening in closed session to discuss agenda item 8 under Texas Government Code 551.071, consultation with attorney. You want to put them together? Okay. So let me just restate that. I announce that the board is convening in closed session to discuss agenda items 8 and 9 under Texas Government Code 551.071, consultation with attorney. Date and time. And today is January 28th, and the time is 6:24 p.m. Thank you. I did. Oh, fully. Sorry. And the item, specifically, the item is to receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN 23000398. And then item number 9, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN 17005824 in the 345th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. And it's still January 28th, 2026, and the time is now 6:25 p.m.
Session, it is January the 28th. It is 7:39, and we are now back in open session. And I believe our chairman is now joining the dais. Okay, so we're done with all the close for now. We're not going to receive the report. We're not receiving the report. Of the security staff.
So we're back on item.
You took
item
one.
3. We did 2. Yeah. Dr. Lee, we did item 2, right? So we're on 3. Thank you, Vice Chair May. We're now going to proceed.
Yes. Is there something?
Members, we're going to move to item number 3, discuss and take appropriate action on a resolution providing board guidance to staff regarding Central Health System Transformation Strategic Plan as recommended by the Strategic Planning Committee. And I believe Dr. Lee and Monica Crowley will be presenting.
Okay. Thank you, Chair Rodriguez. Managers, tonight we are ready to take action on a resolution that provides guidance on Central Health System Transformation Strategic Plan and the path ahead. We've been discussing this item for several weeks, and as you may recall, this resolution establishes the foundation for achieving 2 ambitious moonshot outcomes within 10 years by 2035. First, a 50% reduction in health disparities in our community, and second, a 5-to-1 or better return on taxpayer investment. The resolution also clearly outlines our vision and direction for building a coordinated system of care that delivers timely, affordable, high-quality services for our patients. Over the last several months, you all have provided very thoughtful and constructive feedback on the language we drafted and proposed. I also want to especially acknowledge the leadership of Vice Chair Elisa May in her chairmanship of our Strategic Planning Committee, bringing this forward. In your backup, you'll see a final redlined version of the resolution that includes all of the specific changes discussed at the December 17th Board of Managers meeting and the final feedback our Strategic Planning Committee provided on January 14th. Monica Crowley will provide a brief overview of these final changes, and assuming we've captured everything correctly, we will open things up for you to discuss and hopefully take action on this resolution. So with that, I'm going to turn this thing over to Monica to review the final resolution. Over to you, Monica. Thank you.
May I ask a question, just a clarifying question?
Sure.
Is this what we voted on out of committee?
This is the version that you, so yes, and I've got the red line that demonstrates this is the red line, and then this is the version that's got all of the changes accepted.
Okay.
And these are the only change that was made to this. The things that are in red are the additions that you made during the committee meeting. And there was, if you look at number C, in adding, I'm going to go to number C because it's late, and I'm going to go to the only one that's not exactly the wording that we got from you guys out of the committee. Kind of trying to make sure that there was clarity, we got some input and shared that with Manager May, and it seemed like number C captured the intent and included all the words that the managers had provided, but we were trying to make it flow and provide a little bit more clarity.
So what words are different than what we voted on?
So if you look at in number C, what was voted on, it said, I'm going to read it the way that it was first.
When we voted, that's
when
what
you
I'm comparing
voted, yes.
Okay.
And so when you voted, it said the CEO shall prioritize direct delivery of clinical services by the Central Health System entities while cultivating high-performing partnerships and avoiding duplication,
grounded in shared accountability, assigned incentives, performance on board-approved benchmarks, and clear board-approved governance structures while avoiding duplication that promote a seamless, high-quality patient experience across the continuum of care. Okay, what we changed it to, or suggesting changing it to, is the CEO shall prioritize direct delivery of clinical services by the central health system entities grounded in shared accountability to promote a seamless, high-quality patient experience across the continuum of care, period. The CEO shall do so utilizing high-performing partnerships, aligned incentives, board-approved benchmarks, and clear board-approved governance structures while avoiding duplication. So we just turned it, we used the same words and turned it into 2 sentences.
So that it would flow better.
Okay, y'all can keep talking about it. I'm trying to understand, is this any content difference from your perspective?
From our perspective, it's absolutely not content difference. It was just one long, kind of complex sentence that had been kind of cobbled together during the meeting. And I do think that part of the direction that we got was to, in some of the areas, take the content from the meeting and make a proposal about the wording. So this was the one, instead of having it be one really long sentence, we got some help turning it into 2 sentences that has the same intent.
It's going to take me a minute to read it to really understand what was changed, so you could go on.
Yeah, so
Go
I
on.
have, yes, Chair. When I saw this at the Strategic Planning Committee and I'm on it and voted for it, it was kind of thrust upon me, so just reading it as one integral document, I started getting confused about how it says someplace about rely on, 1, 2, 3, third paragraph of the top of the resolution, third paragraph, and it talks about identified through the 2022 Community Health Needs Assessments, the CHNA. So it's a long time ago, I think, in a way too, but drawing on that. But then you get to F, and then I guess the words that trouble me most is in the sentence that says, third sentence, the updated CHNA will confirm and extend the findings of the 2022 CHNA. And I don't think we intend to say that it's just gonna rubber stamp it, but it kind of has that feeling to it, So I really don't want to wordsmith it, but it just seems like it's more, whether we're assessing against the prior findings, the proper words, but I don't think we want to say that, what it says here. And then also, I do want to ask, aren't the CHNAs supposed to be done more frequently than, it's a long time ago, right? Isn't it supposed to be done like on a more frequent basis than what are we coming upon?
So this would be, if it was completed in it was completed in the 2022 CHNA. I think they're typically done every 3 years, and we participate with the city and the county and the larger hospitals on the CHA-CHIP process, and I think community care is on track.
I'm gonna ask.
Yeah.
I'm new. I don't know what these.
Sorry. The
acronyms are.
community
I
health
remember hearing about the
assessment
CHIP
and the
earlier
community-
and something
yes.
else, but I don't remember what the acronym.
Sorry, the CHA-CHIP is the city and the counties. It's the community health assessment / community health improvement plan. That's something that's done that helps drive federal funding and state funding. And we participate in that on a 3-year basis. Central Health historically has done a staggered demographics report and a community health needs assessment. We haven't had, because we haven't operated a hospital facility before, we haven't had the same type of timing requirements that community care has had as a FQHC. And so we're kind of trying to standardize things and get on a standardized track for every 3 years now with community care by joining together and doing a joint safety net focused community health needs assessment jointly with community care. But to your point earlier, that is a fantastic point. And I think when we look in the third paragraph at the beginning, what we're trying to do when you say we're looking at closing the longstanding gaps, so the 2022 Community Health Needs Assessment teed up the service delivery strategic plan that we're in now, that is that 7-year healthcare equity plan that was developed as a service delivery strategic plan that's a 7-year plan. And so we're in year 3 of filling the gaps. But I think your point about what if the updated Chana does not confirm the findings? So I think we do want to be open. We still want to fill the gaps that haven't been filled, that we're in the process of filling. But to your point on number F, could we make an amendment here that, around the updated Chana will revisit the findings of the
Yes,
2022?
that word works for me,
Okay.
revisit.
And so right now, I'm striking through David, I don't know if you and Hasib have got this, but it's the updated Chana in number F, we're gonna strike, confirm and extend. I will say the updated Chana will revisit if, as a potential proposal from.
So how do we wanna take up edits? Do we need to make a motion for them, David, or do we just get a consensus? Okay, got it.
So we need to offer it now.
Uh,
Do you want me to make a motion, or do you want to wait?
no, I think we'll just wait but we have that one down, identified.
Okay, I have an edit. I appreciate what you were trying to do with C, but it does change the meaning a bit. So I think I can fix it with just an edit here. Okay, the phrase while avoiding duplication was meant to modify the first sentence, not the second one. So by putting it at the end of the whole thing, we've lost the meaning, because the thing that's the way it was originally, it was saying that we were going to prioritize direct delivery of clinical services by our system entities while cultivating high-performing partnerships and avoiding duplication. So basically, we were acknowledging that we have partners that we do direct delivery of clinical services with. So we kind of lost that, and we used you've got utilizing here instead of cultivating, which is a different direction. Okay. So I think we could fix it by saying the CEO shall prioritize direct delivery of clinical services by the central health system entities while cultivating high-performing partnerships and avoiding duplication. And then you could start, period. The CEO shall do so do so.
Through.
I'm sorry, what?
Shall do so through high.
Yeah, there you go. Shall do so through, shall do so through shared accountability, aligned incentives, board-approved benchmarks, and clear board-approved governance structures. I think that'd get the modification back where it was originally. Does that make sense, Monica? Yeah, you might need to modify.
Promote a seamless, high-quality patient experience, across the continuum of care.
Now, you can keep the end of that. So you could say the CEO, I'm sorry to do wordsmithing, y'all, but I didn't expect a change. I didn't do my homework and didn't notice a change from what we had originally, so.
Okay, so then we would have another sentence. So across the continuum of care, and then the other sentence, the CEO shall do so utilizing high-performing partnerships, aligned incentives, board-approved benchmarks, and clear board-approved governance.
Well, what do you have as the first sentence there?
The first sentence is the CEO shall prioritize. Thank you. The CEO shall prioritize direct delivery of clinical services by the central health system entities while cultivating high-performing partnerships and avoiding duplications. The CEO shall do so.
Well, then you can keep to promote a seamless, high-quality patient experience across the continuum of care. You can keep that in your first sentence and then go into the CEO shall do so through.
Shared accountability,
Yeah.
aligned incentives.
Yeah.
Okay.
Yeah, and that's an easiest way to fix it back to two sentences.
Okay.
So if you've captured that, I can. Okay, so Manager Mercedes, sorry.
Yes, thank you. May I suggest that, it seems like we're making some significant edits, that we take it, because I don't feel comfortable voting on something without really seeing all the edits that have been made. Could we vote on this at a later time after the final draft with compiled edits that had been made?
Yeah, but let me clarify, I'm just taking it back to what we already voted on.
Oh, I'm not disagreeing.
Yeah.
I'm just saying, I just wanted the final version that we're voting on. I would like to have a copy of that before voting. So that is my, I'm suggesting if possible, because we're, like, I don't know exactly what, Monica captured, what your intent is. We're just making all these changes.
David, is there any
edits.
way that we could add that in right now? And then I think it's as the resolution, I think somebody reads it in. Is there any way that we could, I think that we've captured this.
Well, let me ask a kind of a process question. Is there an urgency to pass this resolution today, or can we get all of the edits and then move on, since we do have time? The time is getting away from us in terms of just the board meeting, so I don't know if the administration wants to answer that question.
I mean, on that note, on the same note of time, I think moving into another board meeting gets other board meeting time away from us. I think we're really close. It seems like there's this is a very material edit. I think I'm okay to vote on it as heard. I mean, I don't know how everyone else feels. I think it's very important, however, to have our treasurers buy in on it. If there's any way we can get it, that at least that paragraph, would you feel, may I address, if the treasurer would feel comfortable viewing that one paragraph typed out, then perhaps that could accommodate it, because the other edits are in front of us.
Well, I would feel more comfortable seeing the final draft, and also I don't know if there's gonna be any further edits from other board members as well. So that is really it. So I don't wanna constrain folks. We can all make whatever edits we want to this document. I just want us to be in a place that we all can vote on the final edited document. That's all I'm asking for. I apologize if I'm being difficult here.
No, you're not.
But I'm just trying to read the final version, what I'm voting on, because this is a very significant document, and I don't want to feel like I'm rushed into it. That's my personal stake. So if you want to vote on this, I will definitely abstain from this vote, without seeing the final version. Thank you.
Thank you. Are there any other comments or edits? I had one, but it's a clarification. One, to see if it clarifies anything, and that is on the third paragraph when you talk about the 2022 Community Health Needs Assessment. I think this goes to Manager Jefferson's question. Is it feasible to just add at the end of that comma as amended from time to time, which would capture any future community health needs assessments.
I would be okay with that, but let me make sure I understand. This is the framework for developing the strategic plan, right?
Yes.
It's the direction
Yes.
So-
for Pat.
Yeah, I'm okay with that, and then if it would be okay, I would like it to make a motion to amend it to include the language from myself, Manager Kitchen, and Chair Rodriguez.
So since we have a motion, do we have a second? So is there any discussion on it? From either the board or the administration? Yes, ma'am.
Yeah, discussion is where's the final version to vote on? That's what I'm asking for.
So the motion is to amend it, and I think after we amend it, we can print out a clean copy for everybody. If that's,
That because there's a motion on the floor, and maybe in the meantime,
Just to make sure we
can
capture
the
it.
staff
Yeah.
make it the changes so that it can be seen, and then we can
Yeah, I
take the
just
vote
want to make
later?
sure because
Later.
in the past, we've amended this and then when the edited came, it's not exactly what we
same.
asked for. Just for
I hear you.
clarity.
I understand.
I hear you. So,
maybe we can
so
just
there's a
delay.
motion, there's a motion on the floor with a second to amend the document with the edits we just discussed, with the caveat that we'll have a printed copy of that resolution before we vote. For all those in favor?
Aye.
Aye. Those in favor, it's unanimous, so there's nobody against it and nobody's abstaining for it. Okay, so I'm gonna wait to ask for a motion, and if we can do that, then can we move to the next item? Well, David, do I need a table or just pause on this item while we wait for the, same thing? Yeah, well, we're gonna move to item 4, discuss and take appropriate action on the objectives and hiring of a board governance consultant. While we wait for the printout of the edited resolution. Members, in consultation with our Travis County attorneys about how we as a board might participate in the hiring of a board governance consultant, which I think we have the support of the board to do. They've offered a suggestion that the board could designate the chair and vice chair to engage with central health purchasing staff to review the potential candidates and provide input with the purchasing staff, ensuring that the process follows district rules. And one, I'd like to hear everyone's thought on that approach, as well as any suggestions you have for our input should the board decide to take that route. Now, you all have in front of you a draft of the, I had it right in front of me. A draft of the scope of work. And I think we had one feedback already, which I thought was a good catch. Yeah, if you don't want to say. Manager Jefferson pointed out that there was no, whether there should be either preferred or required qualifications on the scope of work. And I thought that was a good suggestion. And David, I think I just sent you an email while I was not in the executive session. I sent you an email just suggesting some language and really deferring to you all about it. But the question is like board governance experience with a hospital healthcare district board, comma, either preferred or required. So I would just put that out there to get you all's comments, but I wanted to go around the room and just get everyone's thoughts about that process, both with the attorneys recommended and then also the scope of work, if you want to take a second or a minute to review that. And by the way, the scope of work was created by the administration, and then I know I gave some edits around it. So it's not a board document per se. That's why it's draft, because I wanted to make sure that the board had an opportunity to provide input.
I have a quick question.
Yes, and then.
Sorry, don't mind my ignorance. Team of 10, what is that?
Team of 10 is just the governance concept about how there's the 9 board of managers and the president. That's the governance piece. That's what's meant by team of 10.
Thank you.
Yes.
I have two thoughts to add to the scope of work. One concept is, I don't know where it would go, it might go on the second page, but when we're talking about a facilitated governance retreat, I wanted somewhere to note that it would be helpful for us when we're understanding best practices and peer examples to include those related to the structure of a health system with multiple entities. So, and then the second thing is, because of our structure and the way I wanted to add to this, at appropriate points, I'd like the consultant in their deliverables to also be able to talk to our deputy administrator as well as our CEO. And I'm fine with the process.
Any other, yes, Manager Jeffrey?
I was struck by the length of the engagement being a year. Is the idea for the consultant to see all, what a fiscal year workflow looks like?
I think it's up to a year, not the whole year if that's not needed. I think part of the process that I've seen typically is a board assessment survey, one-on-one interviews with the board members and with the CEO, and I think Manager Kitchen mentioned also the deputy administrator, and then having conversations about what those priorities are, and then bringing together a series, if needed, a series of retreats. And given the time period that if we prioritize this, we might do this in 3 months, right, or 6 months. But given all the time period, I think the idea was to just up to a year, but not necessarily if we need it. I think one of the end deliverables will be some of the things that we've observed around making sure that we figure out a way to govern. In other words, the board expectations with the administration or with the president. X number of days that we get all the materials beforehand, maybe 3 days before the meeting, we submit all of our questions, allowing administration to have time to answer our questions. Some of the legal processes I've learned from the Travis County office about when they post and what's needed in order to make sure they have a legal review of our agenda setting. There's a lot of different pieces to that, but I think it's also going to be driven by what the board feels they need to make sure that we're working together and moving forward with a good governance process. And then we'll have an opportunity, I think, in the retreats to kind of work that out. I think the timetable really is going to depend on us and what we think are the issues that we need to get resolved.
And then the other thing, I can't find where the action sheet is for this in the packet. Numbers?
Oh, the mic.
Yeah, what agenda item? I was trying to figure out what we're actually voting.
Agenda item 4.
In the motions are.
But where's the
So
page?
there's no, the motion, sorry, the motion that we're gonna bring forward is to, that the board delegate to the chair and vice chair the authority to provide guidance to the central health procurement staff on selection of a board governance consultant. I think in consultation with the Travis County Attorney's Office, they recommended that that's the appropriate process instead of us kind of going through a procurement process directly ourselves.
Okay, so in that regard, I just want to, the reason I asked about what the required and preferred qualifications of the consultant would be is because sometimes these consultants have their own philosophy of governance, and I don't know whether it's a book they've written or, paper or whatever. And so I would like those who would be making the decision to be aware of that. And my personal preference is that we not have somebody tied to a particular model that we don't know about.
A model or a theory of change. Yeah. And I forgive me, but I forgot to mention that this item was really was brought forward in the last year. So there's been I don't know what the right word is, and
We've been working on this for a while, and the full board voted to have the board training as part of the table But, so we've been talking to different consultants for a while, but your point is well taken and certainly can be, certainly
Part of
can
the
be
consideration,
part of the
absolutely.
consideration.
Because, for example, the team of
Yeah.
10, I mean, that can mean, and
Yeah, it can
in
mean
the
something.
school district world, it means, team
Yeah.
of 8 means something. But anyway, so that can mean something. And I'm not necessarily opposed to it, I just kind of want to know if we're being guided along a certain philosophy. And I'd like to know that, but I'm good.
Yeah, yeah. Well, I think, and we'll have plenty, I don't think it's a theory of change. I think what we're trying to recognize is what the board has said that we need in order to clarify roles and responsibilities with the administration. And I think probably what's gonna end up happening is, I think the consultant's gonna be talking to all of us and seeing what the will of the board is and what the priorities are around the needs that we have. Manager Kitchen and then.
I'd suggest we just say as a team instead of team of 10.
Sure.
To avoid any
Yeah.
misconceptions.
Yeah, we can do that.
Of what that might mean. I mean, I think the point is we're trying to work as a team.
Yeah.
The other thing I would say is the motion is not, motion just says the chair and vice chair. And because this is spanning 2 years, it's actually chair, vice chair, past chair, and past vice chair. So,
I'm fine with that, and Dave, I don't know if that's less than a quorum, so
it's definitely less than a quorum.
I'm fine with it unless there's a legal issue. It's fine, okay.
I just have a comment.
Yeah.
With the turnover of the board being what it is, we discussed this. I like Ms. Jefferson's comments; they're very poignant. But I think that compressing this process would be very effective since there is turnover of the board. And I think that part of the things I would like to see come out of this is a handbook or something for future board members to then sit down with said consultant or whomever to say, welcome to the board, these are the rules. I think it'd be a very productive thing to do, to get out of this finally. But I think to compress it would be very effective for me personally. So,
thank you.
Well, I concur with that. I have a question. Did we budget for this, Jeff? And what are we expected, and where would it be? Where would it fall under? What budget line item? And the cost that we're anticipating not to exceed a certain amount? Because I don't recall this. So Jeff, do you have any input in terms of where this will come from? And should we actually designate not to exceed a certain amount?
I don't know specifically. We've talked some about that. I don't know. It will come from the administrative budget, but I don't know exactly.
Can you remind us what the administrative line budget is
Right.
budgeted for?
It is budgeted. We have a budget for board consultants. I can't tell you the number off the top of my head, but just know that when we were planning the budget last year, we knew that it was likely that we were going to be hiring a consultant or two, just because conversations had already started. So we did budget for it.
So you did budget, so do we want to not to exceed a certain amount? Do we have a recommended number? I don't want it, I agree with the compressed, but also I don't want it to be an open amount that we, again, we need to be good stewards to our tax dollars, and also, I think we kind of have an understanding what governance is and a role. So if any suggestions, I would be happy
Yeah.
to entertain.
I don't know, Bella, if you have a thought before I recognize Matt.
I think
Manager
we do
Maloney.
have procurement levels, and I don't know if we want to, stick to one of those levels, or, whatever's the will of the board as well. I mean, I don't know if I should throw out a number until we see, proposals.
So let me just ask this from a legal
We
perspective.
do have to ask for a quote, by the way. I was
Yeah.
just,
Texas Procurement Act has a certain, like an exception for services, or is there an up to amount, not to exceed? I think is it $50,000? I'm trying to remember.
It is. I think
Thank
we're
you.
researching whether that might have possibly changed. But
Got it.
yes, we're currently under the operating premise that the 3-bid process is 50,000.
Yeah. So not to exceed 50,000.
So could we include that language? In
I-
our
Yeah,
whatever?
I think that's possible because, I mean, we could, if we need them for more, we can always come back and ask for an amendment or a motion to it. But if the board wants to put in not to exceed amount, I think that's reasonable.
But if we did not even include that, it will fall back on that policy, correct? Regardless.
Yeah.
Yes, and we always have a not to exceed amount in our contracts.
Okay,
This
so
is- yep.
so then we don't need to add it unless they want to come back for more.
Then we'll leave it alone and.
I'm not sure where that landed, to be candid. Hey, you like that? That said, however this fits into the framework, I'm really not wedded to any of this concept. I mean, I like this. I like the changes. Wherever we go, great. God bless us. And, you know, my preference would be not to put a ceiling on something. 2 reasons. First, I think we tend to engineer our proposals around the ceiling. And that's something I've seen dozens of times, you know, for procurements that I've put out. Secondly, I would prefer to be Socratic about it, see how people respond to something open-ended like this, and allow us to make the value assessment of the quality of the product they're giving back to us in the response, and also what they're proposing. I mean, I would suggest just right off the bat that a handbook included in this would likely, you know, go over that might be a secondary engagement. But I would be interested if somebody were like to put out something that were like 87, and it's a very high quality seeming response and product, and it's extremely detailed, and it's something that we would have ruled out because we had put a ceiling in before, but that would have given us serious value for that extra whatever amount. And so my preference is to use whatever framework we can to be as Socratic as we can, and still make value assessments that I know this board will continue to make. This board is very frugal when it comes to taxpayer money, I think, but I would still like to know what the buffet of options is.
Thank you. Any other feedback? Elisa?
No, I'm good.
So what's the motion?
So,
Thank you. Here's our motion. I move that the board delegate to the chair, vice chair, and the previous chair and previous vice chair authority to provide guidance to the central health procurement staff on the selection of a board governance consultant. Do I have?
is there a second? Second. Dr. Martin seconds. So having a motion and a second, all of those in favor?
Aye.
And the motion passes unanimously. So we will go now to item.
Chairman,
Yeah.
at your discretion, I think I might have misspoken earlier. I don't think we've touched item 2 yet, the objectives and key results for Q1. So at your discretion,
Oh, yeah.
we could.
Great. Item two. So we're gonna go back on the agenda to item 2, receive an update on fiscal year 2026, Q1, FY 26 Q1 system objectives and key results performances.
Great. And I believe there's a handout coming around as I begin, if that's okay. Oh.
I'm sorry,
I think so.
Manager Busev is probably gonna need to leave in a few minutes. I don't know if we have the resolution that's ready.
And is it ready? Yes.
So you're printing it out? Okay.
Chair, can I ask a
Yeah.
question? It's 8:30 almost, or 8:21, and we have a lot to do. I'm wondering if our CEO, I mean, how fast he could do this, or if we could look at we got a lot of really good information in backup, and I'm wondering if, to allow time for some other things. It's just a thought.
I'd like to prioritize the motion to be printed, because I know the one of our managers has to leave. But in the meantime, Dr. Lee, is there a priority about like what the next items you'd like to cover to make sure that we get to those and push the rest of them out?
Maybe I could follow Manager Kitchen's invitation and hit the high notes of this in like 2 minutes and allow for any questions.
Yeah, that'd be great.
So just to get straight to the point, there's a one-page summary that was just handed out to the board. This represents the system roll-up of the 4 main objectives: creating the simplified patient care journeys, building the comprehensive system, demonstrating the value of community support, empowering developing our team. All of them came up in amber, basically. And then you can see to the right the 12 key results that are linked to those 4 objectives, and you see a rainbow. And the key point I want to make actually for the board and for all the staff who may or may not be listening at this hour of the night, but rainbow is good. Rainbow is good is my key point. If it were all green, that would tell us that we probably weren't stretching hard enough. If it was actually all red, I'd be okay with that. Rainbow is really good, and this is right where we want to be. And the key insight I'll share, just to cut to the point, is that actually when we reported this out as the executive team, we went through result by result, there was an aha moment, which is you realize that data sharing, which we know we've been prioritizing, but smooth data sharing internally within the 3 component parts of the organization was a key barrier to our ability to accomplish many of these. And so just to cut straight to the point, that insight alone has made this whole exercise very worthwhile. So we're going to bump that up in priority. The other key thing I want the board to take away is that we are collaborating now in specific and aligned strategic ways that are directly downstream of board-directed objectives and key results from last year. You may recall the board approved these in June of last year. So we are evolving toward that kind of management system where the board's strategic direction in the annual planning process cascades into this quarterly, monthly, weekly set of activities that really percolate through the entire organization. And we're not at the level of maturity we will be at, but this is the early stages of a mature management system. And I really want to compliment the staff and team. Willingness to show the yellow and the red is a big step. And I want the team to know that I love seeing this rainbow and look forward to more. So that's my very brief 2-minute version. Happy to take any questions from the board.
Yeah, thank you. Members, any questions? Does it?
Just brief suggestion for future. You don't have to do it right now, but it might be I like the 1-pager. It's helpful. Might be good to add some notes at the bottom that just help us understand how the scores are calculated. Because I can't tell from this, and I'm sure it's in your backup, but I can't tell from this if we're saying that our goal is to increase unique patients with coverage by 5%, and we reached 0.6. What does that mean? But I don't need to know it right now. Just this will be more useful to me for future. If you have put some kind of notes on the bottom about, but it's very helpful to have a 1-pager.
Yeah, Manager Tricia.
When I read through this, this looks good, and it looks like we have some goals to achieve throughout the fiscal year, so this is good. But seeing some of the specificity of the OKRs, was it operational, another key?
Objectives and key results.
So seeing the specificity of it, I was wondering, this is capturing data and results from Central Health and Community Care, and is it Sendero? Is it across the board? And if so, I see Tara is in the audience. So I was the chair of the Community Care Strategic Planning Committee, and so I was just wondering how we make sure that there is alignment with it, with these being so specific and precise.
Mm-hmm.
How is that achieve with collaboration with those other entities?
Yes. So briefly, yes, it is a system-wide view. We've met as a unified executive team now, this is the end of 2024, I believe, and developed the objectives and key results together with about 19 top executives across the whole system. And then from there, the executives below them, the senior leaders and directors, took those key results and broke them down further. So there are probably 100 different named initiatives that are below these 4 objectives at the board level that all link up in rational ways, we believe, to these overall goals. And the best ones cross the entire enterprise. So, for example, one of the most significant is to reduce by half the duplicated systems within the enterprise. We've identified 20 substantive areas of duplication, from revenue cycle to Epic to addiction services, healthcare for the homeless, pharmacy services, facilities, and so on. We are duplicated, triplicated across all those areas, and our goal is to at least get 10 of those over the line this year. And so you can imagine each of those is, by definition, 2 or 3 parts of the system that are working together to align structures and practices and roles and compensation and all those things. So it's a tremendous amount of work, which is why we want to make sure to bring it forward. And we want the board to have visibility to that. And yes, we're working in lockstep together.
If I may.
Okay. And if I can, I want to share my reaction of like, wow, I can't find them now, but the specificity in some of the care models, and I'm thinking, okay, I hope the priorities here are jiving with the priorities that are in the strategic plan with community care, because this affects the healthcare delivery. I saw something about scheduling times or wait times. It was so precise as to, there you are.
I'm right here, and I'll be very brief. I know that it's very late. Just to say, these were developed in coordination and collaboration. In fact, many of the items are actually KPIs that are in the community care strategic plan, and that was intentional to make sure that there was good alignment. So,
Thank you. Dr. Martin?
I went through the backup, and I want to thank you. It's incredibly detailed, and I really want to thank I point out the fact that you make comments, y'all made comments about where you see the shortcomings and what needs to be improved. I think that's very insightful, and I think very critical. And I really value that when I went through all the backup stuff. So thank you. It was good work.
Thank you.
Members, any other questions or comments?
Echo. Implementing OKRs is hard. It's happened, I think, relatively quickly across a pretty broad enterprise here. It's been a complicated one.
Yeah. Thank you. Thank you, Dr.
Thank you.
So we, do we have the motion? No. I'm going back to item number 4.
The motion.
The motion. Item 5? Okay, let's move to item 5, receive and discuss the compliance plan as presented by the Chief Compliance Officer, and Nakia Smith is going to be presenting for us.
Yeah, good evening, Board of Managers. Can you guys hear me?
Yes.
Great. Okay, thank you for allowing me to join remotely first due to the weather here in Dallas. Today, I'm going to provide a high-level overview of the updated Central Health Compliance Plan. So my update shouldn't take very long. I know we're limited on time. So the compliance plan it's going to include key governance updates. They're going to plan our pathway for the rest of the year. But my main objective here is to get the board's approval or consent to move the compliance plan back to the executive committee. So this item was brought to the December meeting, and I think you guys ran out of time, but it was very timely because I made a few updates to the plan. They were very, very high level, but the updates were really intended to make sure that we align the compliance program with the bylaws and that we take our governance cadence through what we've outlined in the bylaws. So this is really an informational item. The backup is in your board packet, but my presentation is really focused on board policy oversight level, not like operational detail. So the first slide just outlines and defines what the compliance program is all about. It really paves our structure. It includes our governance, our reporting cadence, and really the key program elements that are aligned with the Office of Inspector General's compliance framework. That's where we get the 7 elements of an effective compliance program. I want to point out that the plan has gone through several revisions. So again, I want to get the board's consent to have me take the draft back to the executive committee so that we can review the changes that I've suggested and then bring the full completed final plan back to you guys for approval. So not really a motion, but just an approval on the pathway, the governance pathway.
Manager Kitchen.
Just a quick question. So maybe this will be when it comes back to us, but the reporting cadence to the board and the content of what you'll be reporting to the board, is that in here? I didn't see it, so I'm just, or does that come later? Or does that come later?
Yeah, so I can kind of go over that pretty high level. So the reporting cadence that's outlined in our bylaws is that the compliance committee and the compliance program rose up to the executive compliance committee, the executive committee of the board, and then the final board of managers has the final approval for oversight of all compliance activity. And it's actually on the next slide, but I can talk at a high level to it. So my idea is that any documents that we create, there it's at the bottom. So basically one of the things that I'm working on in developing the compliance program for Central Health is defining our governance process for the company. And that'll outline who sees what and when. And I also want to establish a cadence for reporting that actually aligns with the bylaws. So as I mentioned, reporting should be compliance committee, then to executive committee, and then the final approval would be board of managers.
Okay, so we're going to get it later when it tells us how often and what the report's going to look like. Okay, that's fine.
Yeah, that update is on my next slide. You're just moving me right along. So basically on the next slide, I wanted to share with you my key priorities for the next month, just to show what I'm working on. So for the next 30 to 45 days, I skipped my second slide that has this detail, but I'll be bringing a compliance baseline risk assessment. That risk assessment really informs our audit and monitoring plan. So I'm going through that process now. I'll be taking that to compliance committee and then to executive committee. Next month, I want to present to the executive committee our draft summary of deliverables. That'll be our calendar, the things that we'll be working on through the year. And then I also want to include the cadence on what I propose as the items that'll come to each committee and when. So it'll be like a review and a recommendation. And then following that, we'll return all those documents to the board of managers for your final review and approval as appropriate. This really aligns our program so that we have board visibility. If there's significant compliance risk or program updates, of course, those will come to the board consistent with our normal governance cadence. But the other deliverables are those that kind of framework documents. Those are the documents that you'll eventually start seeing every year on an annual basis. I actually met with the team this week to kind of start putting our calendar together, but it doesn't block those things that'll be coming to the board as ad hoc items. Does that answer your question?
Yes, and we're not voting on it today. We're voting on
Correct.
Yeah, we're not voting on it. And Nikki, I think, if I recall, there was a quarterly, once you get to the cadence of those annual documents, there's also quarterly updates.
Yes.
To the board. Yeah.
So a part of the actual cadence will be quarterly updates to the board and to the executive committee of the board. And then you'll also get like an annual review of the compliance program that'll be done annually in December. And then you'll also see the timeline on what those items are that we'll be bringing to the board. There are items that the board has to approve. For example, the compliance work plan, the audit plan, you'll always receive the risk assessment at the end of the year so that it frames our work for the next year. It's just a little wonky this year because we're starting a little late, but bear with me. You'll see more documents in the first probably 5 months that you'll be approving. But then next year, as we formalize our compliance program, it'll be a normal cadence where you'll be accustomed to seeing certain reports on a quarterly basis.
Yeah.
If you can go back one slide, I did want to just make a few updates. I know that that there was a question in the last meeting on what I was working on in the current focus. As I mentioned, I'm working on a compliance risk assessment. You'll see the outcome of the risk assessment. You'll see the key priorities that the team will be working on throughout the year. We're developing a risk-based audit and monitoring program. This again will align to the risk assessment. You'll get that, and also we'll be asking the board to actually approve that. I did want to touch on the policy and procedure process because we talked about that earlier. At a high level, I just want to let the board know that it's one of the key initiatives that I'm working on in developing the board policy governance process, and that we're working to develop and identify the core board policies that'll be brought to the board for review. And so we're planning to bring those back in March, as well as you'll get an inventory of all of our policies. But in that work, one of the things that we'll be trying to determine and we'll be recommending is what board policies does the board, are they required to see, and then lay out what that process will be, and then outlining what those items will be that'll go to like your standard SOPs.
Thank you,
And I
Manager.
think I hit everything on this slide. Are there any questions?
Manager
Kind of went out of order.
Manager Jefferson had a question.
I have questions, but don't feel the need for them to be answered tonight because I know you're bringing this back. So, and I'm glad we're going to see it again because it's kind of long and I just scanned over it very lightly. But I noticed that Exhibit C, which is on 178 of the packet that I'm looking at, Exhibit C refers to a number of federal laws that deal with, compliance laws that I know pertain to the FQHC, to community care. So just, I'm wondering, to what degree are we doing this for best practice, or does this actually apply to to central health?
So the laws that are outlined in the appendix align to us as a system, because we're laying out a framework of how do we work across our system collectively. It doesn't replace any policies that are being done at CUC. It just aligns that in our work as a compliance program, as a system, we'll also be following the laws that our entire organization should be following. So there's a few that we'll pull out to make sure that we're in alignment. And when you think about the FQHC, we want to make sure that we're doing our due diligence for oversight of the grant. And so that's some of the work that may land on the central health audit plan to make sure that we're doing that work appropriately as an oversight, really.
Okay, and so, but in terms of central health also being a direct provider, and, there are, I would imagine some other things that would apply to us, like HIPAA, and then there's some state law equivalents and things that are state law based vis-a-vis, I guess, I don't know, the MAP funds, I don't know. But
yeah, there's tons that we can add in there. I will let you know that we're working on our draft manual that applies to HIPAA, and a lot of that detail will be in there. If we add all of it to this plan, it'll be long. But my intention on taking it back to the ECC is that I want to make sure that we tie some of the elements that are in the plan to our SOPs or some of our manuals. So there's a few more items that I need to add to that document that aren't in there.
Okay, and then there's a reference to team, and I saw someone had in the margins a question about whether the directors referred to the board of managers. In the scan,
and it does.
Yeah, in the scan, I
pretty
much figured that. So I would just suggest that in the next iteration, that it be just more precise, that it applies, except when the context or the logical governance structure would dictate otherwise. Because some of this,
Yes.
I don't think this board is going to be subject to all of these pages, for instance.
You're right.
Yeah, okay.
I'll lay that out in the executive summary. I'm preparing something to put above the cover, so I'll be able to lay that out. Thank you.
And it could be in the part of your definitions, okay?
Yeah. Okay. Any other questions?
Members, any other questions? I think, Nakia, the one question I have, not to answer it today, but I think I'm sort of, I don't know if you're gonna highlight this when you report back, but the ability for the board under their oversight or duty, fiduciary duty, if we feel that we need to have you review or audit a particular area, for example, where is that flexibility in the process? Like when you bring a plan
Yeah.
and we say, we are hearing like this is an issue. I can't think of anything right now. Maybe it's medical records and like different medical record systems, and the idea that that it's not speaking to each other for some reason. I'm just making that up, but where does that fall in the process, or do you plan to also educate the board about what that ability or
Yeah, I think
process
that's a
is?
great question. So education would probably be essential, especially if the board has not managed at that level. So I can definitely add that to our work plan. But to answer your question, so when you do your risk assessment, you identify your risk and you rank them by priority, right? So high level, medium, low. And oftentimes, a lot of the work that we do inherent to our business and the industry that we're in, a lot of the items end up landing in the high. And so you're like, Nakia, how are you going to address all these in a year, right? And so we usually risk rank them. And one of the roles of the board that I usually like to get board involvement is those items that we've identified as high level. Like I'll bring the top 10 risks to the board and I'll say, here's where we landed. I need the board to help me inform what we should focus on as a priority for the year. So it's like an engagement process with the board. And we develop this risk-based audit and monitoring plan because the things that we identify as risk aren't necessarily compliance risk, right? They may be different risks throughout the organization that we feel may bubble up to an issue, and the board may highlight that. And like you said, it's usually through trends. And so when I'm going through the risk assessment interview, I'm interviewing leaders and we're identifying these risks. But at the board level, you may remember something last year and say, hey, I think we should do a review on that. And then we'll add it to the audit plan. And the audit plan is meant to be amended all year, right? And that's one of the things that's in the guiding documents is that it's a working document because you identify risk as you're doing your work, right?
Thank you. Manager Kitchen has a question.
Just to point out that I'll look at this when it comes back to me, but I didn't see it in my first review. So you don't have to answer this now, but I'll be looking for some clarity about the relationship between the chief compliance officer and the board and the CEO. Because I'm recalling, as we were talking about things previously, that there's certain best practices and OIG kinds of guidance about that are designed to maintain the independence of the chief compliance officer, and maybe that language is in here and I just missed it. It is.
It's probably the section that's more heavily redlined.
Okay.
There's a whole section that I redid, so
Okay,
it's
that's
probably
great.
in that
I'll
section.
find it.
Great.
I'll find
But
it. I
I'll
just
do
want
a
to make
better
sure it was in
job
there.
at it. Yeah, one of the things I did that I saw was missing is that the alignment between the CEO, the board, ECC, that was kind of like it was kind of missing. So I spent a lot of time on that section. So we can definitely talk about it as I'm going through the draft. I think there'll be more revisions as we take it back from ECC.
We can talk about it next time. I just want to have a thorough conversation about the fact that, because there's language that you report to the CEO, which I understand, but we need to make sure we understand how does that work in terms of your independence. So.
Awesome. Okay. All right. Thank you. That was great feedback, guys.
Okay, got it.
So, members, any other questions on item number 5? And if not, Nakia, we're going to pause for a second and go back to item number 3.
Great.
Regarding the discuss and take appropriate action on resolution providing board guidance to staff regarding central health system transformation strategic plan as recommended by the strategic planning committee members. You've been provided a copy of the most updated edited version and a clean copy of it. And I'm just gonna ask if there's any questions and Manager Mercedes for that.
I have a question. Can you just really quickly, and thank you for the copy, appreciate it. Under E, the CEO shall leverage the district's statutory powers and financial capacity. That first sentence. Could you explain what that means? So would that have no oversight from the board if you're leveraging the full statutory powers? So I'm just trying, I don't want us to get into the same loophole we had in the past in terms of this is my, in terms of authority, what I can and cannot do. Y'all gave me this authority, but is there any guardrails around that full authority? So I just want clarification on that. And again, I apologize, board members. I'm just, I know we want to vote on this, but I just want to have that clarity.
Yes, the intent is that throughout the resolution, I believe there are areas that describe the budget and the targets and the benchmarks and the policies and the service elements and so on that the board will vote, approve, and specify. And so it's within all of the board-directed guidelines and guardrails that then the directive is to make sure that we deliver as balanced and operationally and financially efficient and effective an overall service as we can. And I think the lines that follow describe the responsible use of reserve, the responsible use of debt, and so on. And that's really what it's meant to speak to, that we have certain abilities to manage the finances effectively, and that we should do so toward these ends.
Manager Kitty?
I think maybe the thinking was, and I don't know if it gets there, but the thinking was if you look at the last sentence, the board must approve capital and financing decisions, which will be presented, as distinct board agenda items. I don't know if that gets all the way there, but I think that sentence is intended to modify this whole paragraph. So I don't know if it gets it, but I think that's the intent.
Well, I wanted to bring it up.
No, it's important.
Yeah, I would agree, and the reminder, the CEO serves at our pleasure, so.
Yes, but we do have to approve the finances, so, okay.
Yeah, we've already.
Oh, that's right. So David, there was a motion and a second, and we took a pause on it. So now we're going back and considering the motion that the board approve the resolution providing board guidance to staff regarding the Central Health Systems Transformation Strategic Plan as recommended by the Strategic Planning Committee with edits from the board conversation. So if there is no more discussion, all those in favor of the motion, please raise your hand. And the motion passes unanimously. Thank you, members. Members, it's now 8:49 p.m. and we're moving to item number 6, discuss and take appropriate action on board compliance policies and procedures, including CMP 009P duality and conflict of interest policy and CMP 009 SOP duality and conflict of interest procedures. And Nakia, I think you're presenting here as well. Matt?
Yeah.
I was going to suggest,
Oh, hold on one second, Matt.
Go ahead.
I have a lot of questions and suggested changes. So if it's not time sensitive, I'd suggest we have some time to sit with this and maybe vote it at our next meeting.
And move to the next meeting. Nakia, is there any? This is just an education item, right? No.
Yes,
voting.
there's not a motion today. I did not bring.
Oh, it's listed as action. That's why
I saw that.
Well, you do have an action. So the only action that I wanted to ask is that the board complete their annual conflict of interest disclosure that you do every year. Yeah, the actual conflict of interest policy itself is not materially changing today. This is one of the policies that I'm actually working on as well. I have a few edits. So in those documents that I'll be bringing to the board next month, this policy is going to be one of the updated policies. So I didn't want to bring that here because there's too many changes to make. So I just wanted to actually have you guys complete the disclosure form based on the current and existing policy. And then we work on creating a new policy through our updated compliance documents.
So members, we have our assignment to fill that out.
Yeah, and you all should have received last year's form to help you complete the form for this year.
Yeah. Thank you, Nikki. if it's okay, we're gonna move to the next item and then have Nakia come back to us with these items, but making sure that we, thank you, that we comply and fill out our conflict of interest disclosure forms. And Nakia, I don't know if there's anything else you wanted to add for that before we move on to the
No,
next
and we
item.
can collect those. I think that if Perla is there, we can actually work and get those from you guys later, since we're limited on time
Yeah.
tonight.
Thank you.
Thank
Is
you.
there a no later date for this? Just, oh, see.
I'm sorry, we do these annually, and I'm not sure of the exact date that we did them last year. But I think that we're fine to bring them back.
Okay. Thank you very much, Nakia. We appreciate it.
Thank you.
And David, you're gonna have to help me here. Which items do we need to go to executive session? 7, 10, and 11? 7 and 11, okay. So I'm announcing that the board is convening in closed session to discuss agenda item 7 under Texas Government Code 551.076, deliberation regarding security devices or security audits, and agenda item 11 under Texas Government Code 551.074, personnel matters, and Texas Government Code 551.071, consultation with attorney. And that is item 7 is to receive and discuss security matters at Central Health System facilities. Item 10 is receive and discuss an overview of legislative and regulatory issues impacting Central Health System. Oh, sorry, that's not right. Not 10, 11, sorry, I apologize. Deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. And the date is January 28th, and the time is 8:53 p.m. Good evening. We're coming out of closed session. It is now January 28th, 2026 at 10:43 PM, and we're entering our open session. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, February 25th at 3:30 PM at the Central Health headquarters here at 1111 East Cesar Chavez, Austin, Texas 78702. And now I'd like to entertain a motion to adjourn. Move, and, okay. So Manager Brinson moves and Manager Mawani seconds to adjourn the meeting. All those in favor, please say aye. Aye. The motion passes unanimously. Thank you all.